Okay, welcome to the next module on genitourinary system. There's quite a few chapters here, so I'll try to make it as brief as possible. So we're going to start off talking about renal diagnostic procedures, and then we're going to move on to hemodialysis and peritoneal dialysis, followed by renal transplantation, and then we'll talk about a few kidney diseases such as polycystic kidney disease, acute kidney injury, and chronic kidney disease. Okay. And that'll be followed by infections of the renal system and the urinary system, of course. And lastly, we'll talk about renal calculi or kidney stones. Okay. Okay, so let's look at the function of the kidney in the urinary system. So we typically have two kidneys. Some people are born with one kidney, a congenital defect, often noted during fetal development when we do an ultrasound. The kidneys drain urine. So, well, first of all, the kidneys produce urine, and then they drain the urine down the ureter into the bladder for storage and elimination. Okay, so one of the functions of the kidney is urine formation. Okay, and urine is a way of the body getting rid of excess fluid, right? So we all know that if we consume large amounts of fluid, we're going to urinate more because the body doesn't want to keep all that fluid. And if we are becoming dehydrated, the kidney is going to reabsorb more water because it's detecting the dehydration status and it's reabsorbing fluid to minimize dehydration, so we make less urine. Okay. So that's the next box, regulation of water excretion. And the body is, the kidneys are constantly monitoring the water status of the body, okay, and the volume status of the body. And if it detects that there's reduced overall volume of the circulating blood, it's going to release renin, which is going to go through the renin-angiotensin aldosterone system. Aldosterone reabsorbs sodium, which reabsorbs water and excretes potassium. Okay. So regulation of electrolyte. So the typical person eats all kinds of foods which will have an assortment of electrolytes in them, but the body wants to maintain the serum with very strict parameters of its electrolytes, such as sodium, potassium, chloride, calcium. So the kidneys have the ability to reabsorb those electrolytes or not to reabsorb those electrolytes and let them go in the urine. Okay, and it's doing this so that it maintains very stable electrolyte levels in the serum. Okay, regulation of acid-base balance. So the kidneys can actually get rid of H+, okay, which makes the serum acidic, and the kidney is one of the main buffering systems of the body. It can produce bicarbonate, right? And bicarbonate is circulating in your bloodstream and buffering any acids that are being produced. Okay, so definitely acid-base balance. Regulation of blood pressure. Well, that's through the renin-angiotensin aldosterone system. It can regulate blood pressure that way. Red blood cell production through erythropoietin secretion by the kidneys. Okay, so that's very important in terms of maintaining normal hematocrit and hemoglobin levels. Vitamin D synthesis, well, it's vitamin D activation. So vitamin D is produced in the skin or ingested in your diet. You typically need about 20 to 30 minutes of sunlight to provide enough vitamin D for the day. But typically vitamin D from the skin and your diet is inactive vitamin D, and it needs to be activated in the kidneys. So inactive vitamin D is cholecalciferol, and active vitamin D is calcitriol. And vitamin D is responsible for absorbing calcium from the gastrointestinal tract. Secretion of prostaglandins and other substances. So the kidneys are very reliant on prostaglandins for their normal functioning. And that's why NSAIDs or aspirin products are potentially harmful to the kidneys. So someone who's taking high doses of some kind of NSAID, such as naproxen or ibuprofen or indomethacin, well, sure, it's hard on the stomach. It's also hard on the kidneys because NSAIDs inhibit prostaglandin production. That's how they act as anti-inflammatories. And they're hitting the kidney by inhibiting prostaglandins, and that can harm the kidney over time. So we never give patients with renal failure non-steroidal anti-inflammatories. Very harmful to the kidneys. Okay. Excretion of waste products that are circulating in the blood, which are basically byproducts of metabolism of the body, are constantly being excreted in the kidneys. The bladder system, well, that's urine storage, right? So the bladder is basically made up of detrusor muscles, and they can expand and allow for storage of urine. And at a certain point, the parasympathetic system is involved in contractions of the detrusor muscle, leading to urination. Okay, bladder emptying. So bladder emptying is really a parasympathetic function because the parasympathetic system causes contractions of the detrusor muscle. So you can actually go back to each one of these boxes and predict what's going to happen if somebody develops renal failure. So urine formation decreased, water excretion decreased, so potentially volume overload. Regulation of electrolyte excretion decreased, so potentially hyperkalemia. Regulation of acid-base metabolism balance decreased, so now we're looking at metabolic acidosis. Regulation of blood pressure decreased, so now we're looking at hypertension. Regulation of red blood cell production by erythropoietin. With renal failure, you have less erythropoietin, leading to anemia. Okay. Vitamin D synthesis. With renal failure, it's decreased, so less calcium absorption from the gastrointestinal tract. What's that going to activate? Well, if there's less calcium that's being absorbed, the parathyroid hormone is going to be activated to break down bones to release calcium from the bones, to maintain serum calcium. And that's why patients with renal failure develop bone diseases called renal osteodystrophies, because there's less calcium being absorbed due to vitamin D deficiency, and there's hyperparathyroidism to break down calcium and release it from the bone. Okay, and that's why you also have elevated phosphate in renal disease, because when you break down calcium from the bone, you're releasing phosphate that's bound in the bone as well. Okay. Secretion of prostaglandins decreased, so NSAIDs or aspirin products will really hit the kidneys hard, okay, and cause more renal failure. Excretion of waste products such as creatinine and BUN, blood urea nitrogen. Well, they're going to be decreased, so they're going to go up in the blood. So we're going to have an elevated BUN and an elevated creatinine. Urine storage is going to stay the same with renal failure. The bladder is still there and still functioning. and bladder emptying is still there as well. Okay. Okay, so let's look at the renal system with aging. So the kidney size and function gradually decrease with aging. Okay, so you can actually think of any organ, and typically over the age of around 30 to 35, we're losing on average about 1% function of every organ in our body. Okay, luckily, most organs have a lot of reserve. So 1% is not going to be that harmful. Okay, because for example, the kidneys, they have a lot of reserve. You can do just fine with 1/2 of one kidney. Okay, and that's why patients can donate a kidney very easily, because one kidney is more than enough to filter their blood. Okay, so gradually over time, the kidneys in older people are more sensitive to episodes of hypertension and episodes of hypotension. Okay, they don't recover as quickly in older people. Okay, the GFR, which is the glomerular filtration rate, is gradually declining, and it gets to about half of what it used to be as a young person. Okay. Contrast media. When we're giving patients contrast media for CAT scans, we have to be aware that in an older patient, it's going to potentially harm the kidney more easily. Okay. In terms of the bladder, the sphincters, so the urinary sphincters that hold the urine, can weaken, especially in females, due to labor and delivery, which has stretched the whole area and potentially injured the urethra, but also due to estrogen deficiency postmenopausally. Okay, so women are very prone to incontinence because they have a short urethra and the sphincter may not be functioning as well. Okay, and women are more prone to UTIs because they have a short urethra. Okay, men are more prone to urinary retention because of an enlarging prostate and not being able to completely empty their bladder with urination. Okay, so women are prone to UTIs because they have a short urethra. Men are prone to UTIs as they get older because they're not completely emptying their bladder. Okay, so we're going to go through a whole host of different diagnostic procedures and imaging tests. So some of the tests we're going to talk about are blood tests. Some of them are going to be tests on the urine and imaging type tests, such as CAT scan, ultrasound, MRI. And we'll cover most of them. We won't cover all of them because some of them are relatively uncommon. Okay, so we'll try to stick with the common ones. Okay? Okay, so I like to think of creatinine and BUN, but more so creatinine as a marker of kidney function. So creatinine is typically made or released, I should say, in the muscles. Okay, so creatinine is released in the muscles and then it circulates in the bloodstream, and the kidneys filter it. Okay, so as we actually get older, we have less and less muscle mass. So you would think, well, the creatinine should go down. Well, in actual fact, it stays pretty stable because the GFR, so the kidney function, is gradually going down as well. So creatinine tends to stay stable at a normal level. Okay. Now, as kidney function abnormally weakens, so a patient who's developing chronic renal disease or someone who has acute kidney injury from something that's suddenly harmed the kidneys, well, they're going to get a rise in serum creatinine. So I consider creatinine a more stable and accurate test of kidney function. Let's look at blood urea nitrogen. So blood urea nitrogen comes from the breakdown product of protein, amino acids. They make it makes ammonia first, and then ammonia is converted to urea. And urea is not toxic like ammonia is in the bloodstream, and it is excreted by the kidneys. Okay, so anything that impacts more protein breakdown or impacts how much urea is being put into the bloodstream from the liver is going to elevate blood urea nitrogen. So let's look at a couple of examples. So dehydration. So if you're dehydrated, your plasma is going to be more concentrated. Your BUN climbs very quickly. So for example, someone who's vomiting profusely and becoming really dehydrated, their BUN tends to climb much faster than the creatinine. Okay. How about someone who has a gastrointestinal bleed? So when you bleed from, you say, your stomach from an ulcer, that blood is going to get reabsorbed into your system. And red blood cells have a lot of protein. The liver is going to break them up, and suddenly your BUN climbs quickly. Okay, so when we see an elevation of BUN with very little elevation of creatinine, we think of dehydration. Maybe a GI bleed is causing this rapid rise in BUN. So it still is a marker of kidney function. It just tends to go up and down more quickly. Okay, so say I had a power drink that was packed with protein. Well, my BUN might be elevated tomorrow purely because I ingested lots of protein in say a power drink. Okay, so so just think of BUN as, yes, it's a blood test for kidney function, but it tends to go up and down much more in diseases such as infections, dehydration, GI bleed, because it's all about how much protein is breaking down in the system, okay, and being converted to amino acids and then to urea, and then waiting to be excreted by the kidneys. Okay, so let's look at the urine a bit. So urine is usually pretty boring, right? So when we check the urine with a dipstick, it's usually pretty boring. And also a culture and sensitivity. We should not have any bacteria growing in our urine. Okay, so that should be negative in a normal urine. And it should be a nice, clear yellow color. It shouldn't be dark, shouldn't be concentrated, it shouldn't have a high specific gravity. Okay, and when we do a dipstick, a urinalysis, there's essentially, it should be negative for glucose, right? Because the body doesn't want to get rid of glucose normally. So if we're picking up glucose in the urine, we may suspect diabetes. And we're going to do a finger stick glucose test to see if the patient's diabetic. Okay, and sometimes we pick up diabetes this way. Ketones, which are from fat metabolism and fat breakdown, we shouldn't have any ketones in our urine. And ketones also occur in our urine in dehydration and starvation states, because the fats are breaking down a bit and they're releasing some ketones into the urine. Okay, we shouldn't have any protein in our urine. The glomerulus is a filter that stops proteins from leaking into the urine. So, because proteins are typically large, right? So if we're seeing protein in the urine, that can be an issue with the glomerulus, especially if we're picking up albumin. So if we're picking up albumin in the urine, we're thinking of diabetes that's causing glomerular issues and resulting in leakage of albumin. Or we're thinking of nephrotic syndrome, where patients are losing large amounts of protein into the urine. Okay, so we shouldn't typically have white blood cells in our urine either, right? That should be relatively clear. And leukocyte esterase and nitrates, which are tests that are an indication of a urine infection, they should be negative as well. So overall, urine is typically pretty boring. Okay, we can send urine for cytology, looking for cancerous cells if we want to. So if somebody comes in and they've had some bleeding and we're thinking, okay, this could be bladder cancer or kidney cancer, let's send the urine for cytology to see if there's any cancerous cells within the urine. Okay. What about 24-hour urine collections? Well, we don't do them that often, but we do in certain situations. So if we're picking up large amounts of protein on a urine dipstick, well, that doesn't quantify it for us. It doesn't tell us how much protein is being released from the kidneys over 24 hours, right? So we can provide the patient with a large container, and they get instructions on urination into the container for 24 hours and then bring it back, and we can calculate exactly how much protein is being excreted by the kidneys in 24 hours. Okay, so in nephrotic syndrome, you're losing tremendous amounts of protein. We're going to do a 24-hour urine collection for protein. Okay, so that would be by far the most common 24-hour urine collection test that we do. Okay, we don't typically do 24-hour collection tests for creatinine clearance. Creatinine clearance has a simple equation that we base on the serum creatinine. Okay, so if you look up creatinine clearance on your computer, you'll see that it's a simple equation based on the age of the person, the weight of the person, and the serum creatinine. Okay, and whether they're male or female. And that gives us a really good idea of creatinine clearance. Okay, and creatinine clearance, why do we care about that? Well, that's actually giving us a indirect value of glomerular filtration rate. And we do care about that because GFR is telling us how strong is the filtering of the kidneys. Okay, and if somebody has a very low GFR, we need to think about the doses of drugs we're giving them, the frequency of how often we're giving drugs, because a patient with a low GFR means they're filtering the blood much slower than a healthy kidney. Okay, so on the left of this slide, where it's saying midstream urine collection instructions, well, we typically want a sample of urine, especially in the setting where we're going to send it for a culture and sensitivity, by the way. We want a midstream urine that's not contaminated by somebody's hands or the container's been touched. No, we want a sample that if we send it for a culture and sensitivity, it's going to accurately reflect what's in the urine and not what's on someone's hands or not what was on the skin of the genital area. Okay, so washing hands with soap really well before the midstream urine, cleaning the genital area with these towelettes, and then males and females have different ways of cleaning, obviously. And notice that as you go down these instructions, it's all about making sure that you get a midstream urine that's totally clean and gets into the container without any contamination. Okay. On the right, we spoke about 24-hour urine collection, and I mentioned that by far the most common one is 24-hour urine collection for proteins, okay? Because we want to diagnose, say, a diabetic, how much protein are they losing in 24 hours because they have renal damage from the diabetes, or a patient that presents with edema of their feet, maybe their hands, around their eyes, and we notice on the dipstick that they have a bit of protein, and now we want to see if they have nephrotic syndrome. And nephrotic syndrome, you're typically spilling about 3.5 grams or greater of protein in 24 hours. So it's a very useful test to see how much protein is being spilled into the urine over 24 hours. Okay, so ultrasound. Well, ultrasound is a fantastic test for the assessment of kidneys and also the bladder. Okay, so just in general, ultrasounds are really good at looking at solid organs or organs that have fluid within them. Okay, so if we think about the kidneys, okay, that's a pretty solid organ, but it also has fluid being produced. The bladder, lots of fluid there, so we get a fantastic view of the bladder. And that's why ultrasounds are very useful for looking at a fetus, because there's a lot of amniotic fluid, and ultrasound transmits waves through fluid very well. Okay, and that's why an echocardiogram of the heart is a fantastic test for looking at the valves of the heart or the muscle of the heart, because there's blood flowing within it. Ultrasounding the lungs, you're not going to hear about very often, because the lungs are filled with air, and ultrasound does not like air. It doesn't transmit the waves through air very well, so we don't get an accurate reading. Okay, so what does the ultrasound look at? Well, we can check the size of the kidney. We can see if there's an obstruction of the ureter, say by a kidney stone. We can see if the kidney is swollen, say from backup of a kidney stone called hydronephrosis. We can see if there's a tumor or a mass on the kidney. We can see cysts on the kidney. So small cysts on the kidney are actually normal. We call them simple cysts. But some patients can have a disease called polycystic kidney disease, and we'll talk about that, and we can easily see it on an ultrasound. Okay? We can also see kidney stones within the kidney. I mentioned, and they don't cause any symptoms until the kidney stone actually leaves and blocks the ureter. Okay? And then it causes backup of fluid, which I mentioned is called hydronephrosis. Okay? So we can really see the ureters when they're swollen and obstructed with a kidney stone. We can look at the bladder. Okay? We get a great view of the bladder. We can see the bladder wall. We can see if there's a mass growing out of the bladder wall, such as a bladder cancer. It shows us if someone's able to fully empty their bladder. So we'll look at the bladder full while it's full. We'll get them to empty their bladder and then look at it again to see if they're able to fully empty their bladder. And that's done very commonly in elderly men to see if they're retaining fluid from BPH. Okay. X-rays aren't overly useful. So an X-ray of the abdomen, or what's called a KUB, for kidney, ureter, and bladder. It's just basically an X-ray of your abdomen. And we can just see things that are typically calcified, right? So we don't get a great view of the kidneys and the bladder just with a simple X-ray. But it will show calcium stones. It might show a really enlarged kidney, but we don't get a fantastic view with a simple X-ray. Okay. CAT scans. Well, CAT scan is a very good test for looking at the renal system, especially if contrast is used. Okay, so intravenous contrast, which can be a bit harmful for the kidney. It can cause a bit of a um, acute kidney injury uh, from the contrast media. But we see the size of the kidney. We see if there's any masses on the kidney. We can detect kidney stones that are blocking the ureter. We can see hydronephrosis. We can actually get the size of the kidneys, the exact size of the kidney stone that's stuck in the ureter. Okay. It'll also assess the bladder. It'll look for lymph nodes that are potentially around the bladder. It'll give us a view of the prostate. So really good test. Unfortunately, it comes at the cost of some radiation. Okay. Okay, so a kidney biopsy is done with a needle, and typically what's done is the skin is frozen around where they want to put the needle in for the biopsy. Often the patient will be given a bit of sedation, and the needle will be advanced until it gets into the kidney, and they'll take a core biopsy of the kidney and send it to the lab for analysis. Okay, so it's not a frequently done test, but if they want to look at the tissue of the kidney, say a biopsy to see if there's a mass that's cancerous, or somebody has glomerulonephritis, which is inflammation of the kidney. There's many different types, and they want to see which type of glomerulonephritis somebody has. Well, a kidney biopsy can be done. So prior to taking a kidney biopsy, we need to make sure that the patient's coagulation studies, so PT and PTT or INR, are normal. Patients usually NPO for 4 to 6 hours prior to the procedure. And then after the procedure, well, we send the tissue to the lab. If there's significant bleeding, we may order a CBC to look at the hemoglobin and hematocrit. We'll monitor urine output since they just had a kidney biopsy, and we're going to be looking for ongoing bleeding in the urine, right? Most people tolerate a kidney biopsy just fine. But if you remember, anything that's invasive in the body, okay, there could be some bleeding into the urine, or we may introduce an infection and cause a pyelonephritis. Relatively unlikely, okay? An MRI can be used. MRIs typically take a bit longer to obtain, and the patient is having to lie in an MRI much longer than a CAT scan. A CAT scan takes minutes. MRIs can take half an hour to an hour. So MRIs give us a good image. They just take more time to obtain. Okay. The advantage is that there's no radiation. The disadvantage is if the patient has anything metallic, then really they're not eligible for receiving an MRI. Because metal objects within someone's body can heat up, and the MRI is a large magnet, so it can cause heating of the metal object and also vibration of the metal object, and it can burn the internal tissue. And worst case scenario, it can actually pull metal out of the body. Okay. So it is a good test for, say, for example, someone who has cancer, and we want to see all the tissues of the abdomen. We can either do a CAT scan or an MRI to look to see if the cancer has spread to other organs or to lymph nodes in the abdomen or elsewhere in the body. Okay, so let's just look at a couple of other tests that evaluates the urinary system, and it's not like, it just depends on the patient's symptoms that'll determine which test we're going to arrange, right? So a cystogram is a test on the bladder, and we just instill some contrast media through the urethra, not into the bloodstream. We inject it into the bladder through the urethra, sorry, and we take images of the bladder. So for example, someone who's been in a car accident and we want to see that their bladder hasn't ruptured, we can inject through the urethra some contrast media and see that the bladder is still completely intact. Or we can do what's called a cystourethrogram in a trauma, where again we just put some contrast media into the bladder and we take x-rays of the bladder and the urethra to see if there's been any injury of the bladder or the urethra. Okay, so say for example someone's biking down the street and they run into a car and their genitals ram into the front of the bike and they got bruising everywhere, and we're wondering, did they injure the bladder? Have they injured their urethra? Well, we can do a cystogram or a cystourethrogram. Okay, so those are pretty straightforward. So a VCUG, avoiding cystourethrogram, is typically done in children. Okay, it can be done in adults as well, but it's often done in children to look for reflux of urine back into the ureters. So children that have recurrent urinary urinary tract infections, we're often left wondering, do they have a urinary tract infection because they're refluxing urine back into their ureters? So we can arrange a VCUG. Okay, so it's just a matter of again injecting contrast media into the bladder, and we take x-rays during urination, and it's going to show us, is there any urine that's refluxing back into the ureters? Because we shouldn't have any urine that refluxes back into our ureters, and that is a risk for getting recurrent UTIs as a child. And if you get recurrent UTIs as a child, and you're getting recurrent pyelonephritis, which is kidney infections, then it's going to gradually harm the kidneys over time, and people can be left with chronic pyelonephritis and renal failure as an adult. Okay, so children who have recurrent urine infections we will do a VCUG. Okay, so whenever we're putting something into the bladder, remember, the bladder's a sterile environment, so we have to monitor for infections after the procedure. Okay, and we encourage increased fluid intake to just flush out not only the contrast media, but the potential for developing an infection. Okay, so any procedure where we're injecting into the bladder, such as a cystogram, or the next one we're going to talk about, a cystoscopy, which is a scope into the bladder, a camera, through the urethra, which gives us a direct view of the bladder wall, and also as we're entering the urethra, well, that's a risk for introducing infection, right? So that can be a complication. So talking about a cystoscopy, that's a scope that goes into the bladder for assessment, say, of someone who had hematuria or who has chronic bladder discomfort. They may need a cystoscopy. Okay, so they typically receive an anesthetic, bit of a sedative. The urethra can be frozen, anesthetized with lidocaine gel. And remember, after the procedure, it's important to monitor for signs of infection because it was an invasive procedure. Okay. So what is the complication of a cystoscopy? It's going to be all about an infection. So cloudy, foul-smelling urine, dysuria, which is burning with urination, urgency, which is the inability to hold your urine, and of course a urinalysis that shows white blood cells, red blood cells, positive nitrates, and a positive leukocyte esterase. Remember, if you get a positive leukocyte esterase or nitrites, always think of urine infection because that's what they signify. Okay. Retrograde pyelogram. So all that is basically a cystoscopy, and then they can inject dye into each ureter and see the upper renal system, so the ureter and the kidneys. Okay, so the cystoscopy shows the bladder and the urethra, and the pyelogram shows the kidneys and the ureters. Okay. Okay, so let's have a look at the questions at the end of chapter 56. One, a nurse is teaching a client who will have an x-ray of the kidneys, ureters, and bladder, so a KUB. Which of the following statements should the nurse include in the teaching? You will receive a contrast dye during the procedure. No, this is just a simple x-ray. Okay, doesn't give us a lot of information. Sometimes we can just see some calcifications in the kidney. If we're lucky, we might be able to see a kidney stone that's stuck in a ureter, and it happens to be calcified, so we can see it on X-ray. So A is wrong. B, an enema is necessary before the procedure. No, an enema is not necessary before the procedure at all. You will need to lie in a prone position during the procedure. No, that's not accurate at all. Prone is when you're lying on your stomach. You don't need to lie prone for a KUB. The procedure determines whether you have a kidney stone. I guess that's the most accurate one. It's not super accurate, but it can see calcium-based stones, so calcium oxalate stones. So whether they're in the kidney and they haven't moved yet, or if one is stuck in the ureter, if we're lucky, we may be able to see them. Remember, kidney stones are small. They're usually 10 millimeters or less for the most part. Some people can have super large kidney stones that are larger than 10 millimeters, and they don't often pass. But most kidney stones are 1 to 10 millimeters in general. Okay, so I guess the answer is D. The procedure determines whether you have a kidney stone. That's the best answer anyways. 2, a nurse is monitoring a client who had a kidney biopsy for postoperative complications. Which of the following complications should the nurse identify as causing the greatest risk for the patient? So A, infection. So infection would be pretty unlikely because this is a sterile procedure. It's always possible, but it isn't the greatest risk. So the greatest risk is bleeding, because you're actually going into the kidney with a needle, right? So hemorrhage is going to be the answer. Hematuria, sure, that could happen. In fact, it's likely going to happen that we're going to pick up a bit of blood in the urine, but that's not the greatest risk. The greatest risk is the one that can harm the person the most, and it's going to be hemorrhage. Pain can definitely occur, but it's not the greatest risk. Number 3, a nurse is caring for a client who has type 2 diabetes and will have excretory urography. Okay, that's interesting. Prior to the procedure. Which of the following actions should the nurse take? So an excretory urography. So to me, all that means is a test where we inject someone with contrast media, and it's usually, well, it can be iodine based, and the contrast media that's now in the bloodstream circulates and gets to the kidneys, and now we can take x-rays because the contrast media is flowing into the kidneys, so we're going to get an image of the kidneys, the ureter, and finally the bladder. Okay, so another term for that test is an intravenous pyelogram, an IV pyelogram, and we used to do them all the time. Not so much anymore because we have CAT scans that are much more effective. So whenever we give someone contrast media, and then so it's going to the kidneys, it's lighting up the kidneys, the ureters, the bladder, before the procedure, we want to make sure they're really well hydrated. Okay, so encouraging lots of fluids before the test. Often there's a laxative or an enema before this test, this intravenous pyelogram, because it's going to make viewing the kidney, ureter, and bladder much more difficult if there's bowel in the way and fecal contents in the way. Okay, so a bit of an enema and laxative they take. Their NPO after midnight, no eating. We always ask if they have any allergies to iodine, seafood, and eggs. Okay, and we're going to check a BUN and creatinine for sure, because if someone has an elevated BUN and creatinine, do we really need this test? Because it could potentially, the contrast media could potentially harm the kidneys. Okay. If the patient is diabetic, we always withhold metformin before giving contrast media because of the risk of what's called lactic acidosis developing because they're taking metformin, and the contrast media can potentially harm the kidneys, causing metformin to cause lactic acidosis. Okay. All right, let's go back to the question. Sorry. Okay, so we're on number 3. So A, identify an allergy to seafood. Absolutely. Withhold metformin for 24 hours? Yes. Administer an enema? Yes. We're doing a pyelogram, or what they called a excretory urography. Okay, so we want to get as much of the bowel out of the way as possible. Obtain a blood coagulation profile. No, there's no risk of bleeding here. We've just injected some dye into a vein, and we're doing X-rays and viewing the kidney, ureter, and bladder. Okay. With this intravenous pyelogram, or what's called an excretory urography. Okay, so no. Assess for asthma. Yes, asthmas can react to contrast media, asthmatics, sorry. So that would be a small risk during the contrast media administration. So the answer is A, B, C, and E. Okay, so not a terribly easy question if you don't know what an excretory urography is. And remember, we used to call it an intravenous pyelogram. Okay, number 4, a nurse administered captopril to a client during a renal scan. Which of the following actions should the nurse take? So a renal scan is really a test that we do to determine how much blood flow is going to the kidneys and what's the GFR. Okay, and it involves injecting a radioactive solution that then goes to the kidneys, and we scan the kidneys. Okay, we can give them a dose of captopril during the procedure to alter the flow of blood to the kidneys. Remember, captopril is an antihypertensive medication. It's an ACE inhibitor, and it can cause a drop in blood pressure, and that's going to be interpreted on the renal scan. Okay, so patients have to be careful when they receive a dose of captopril for a test of orthostatic hypotension. Okay, and they need to increase fluid intake after the test to not only clear the radioactive solution, but also because if captopril was given, it's going to prevent orthostatic hypotension. So let's look at the answers of number 4. Assess for hypertension. No, captopril is an antihypertensive. Limit the client's fluid intake. No, you wouldn't limit the fluid intake because you want to make sure that they don't develop orthostatic hypotension. So you would encourage fluid intake. Monitor for orthostatic hypotension. That's going to be the answer. In fact, whenever we give an antihypertensive, you'd probably be able to figure out this answer just by the fact that antihypertensives can cause orthostatic hypotension. Encourage early ambulation. Not really related. Okay, so 4 is D. Okay, number 5, a nurse is reviewing the results of a client's urinalysis. The findings indicate the urine is positive for leukocyte esterase and nitrates. Which of the following actions should the nurse take? Request the test early the next morning, or repeat the test early the next morning? No. Those two tests are when they're positive in the urine, they're very sensitive for urine infections. So whether it's a bladder infection called a cystitis or a kidney infection called a pyelonephritis, those two tests when they're positive are super accurate for detecting UTIs. Start a 24-hour urine collection for creatinine clearance. No, we wouldn't do that. Obtain a clean catch urine specimen for culture and sensitivity. Absolutely. Since we're now suspecting a urine infection, we want to send off a culture and sensitivity. So it's going to be C. Insert an indwelling catheter. Insert an indwelling urinary catheter to collect a urine specimen. No, there's no need. If an adult is able to give us a good midstream urine for a CNS, there's no need to put a urinary catheter in to get the urine sample. Sometimes in small children, when we really want a sterile urine sample, sometimes we have to put in a urine catheter to obtain the urine that hasn't been contaminated, because obviously the child can't control when they're going to urinate. So that's the only time. In an adult, we get a midstream urine collection to send for a CNS. Okay, so let's move on and talk about hemodialysis and peritoneal dialysis. And these are two ways of removing not only fluid from the body, but toxins from the body when the kidneys are no longer working. So when aren't the kidneys working? Well, someone can sustain an acute kidney injury where the kidneys are temporarily or potentially irreversibly shut down, or from chronic kidney disease, such as from diabetes or hypertension, or a glomerulonephritis or polycystic kidney disease, something that's caused the kidneys to be permanently non-functioning. And now the patient needs some way of filtering the blood, okay? And that's going to be hemodialysis or peritoneal dialysis. This does not replace the erythropoietin in the setting of chronic renal disease, right? So erythropoietin is responsible for red blood cell production. So often patients with chronic renal failure requiring hemodialysis or peritoneal dialysis will require erythropoietin shots to replace the hormone that isn't being produced from the kidneys any longer. So here's an image of the two types of dialysis. Hemodialysis is typically much more common in North America compared to peritoneal dialysis. Okay, there are some countries where peritoneal dialysis is more commonly done, such as in Mexico, but it just so happens hemodialysis is much more frequently done here in the United States. So what's the basic concept? Well, you need a fistula, and a fistula is a surgical procedure where and it's typically done at the elbow. So they attach an artery directly to a vein, okay, at the antecubital fossa. And that allows for tremendous blood flow from the artery to the vein. And that's going to be the access point for taking blood out of the patient because there's nice high flow there, and also for returning the blood to the patient. And what happens in between is it goes through the dialysis machine, and it corrects first of all, it removes any toxins from the blood. It'll correct electrolyte changes that have occurred because the patient doesn't have functioning kidneys. So it corrects volume, it corrects electrolytes, and it removes toxins. Okay, and usually this is done 3 times a week, and each one takes about 3 hours. Okay. Most of the time, patients need to go to a dialysis center to have this done. Some patients have a small hemodialysis unit at home. Okay. Peritoneal dialysis is where a port is surgically inserted across the abdominal wall into the peritoneal cavity, and fluid is inserted into the peritoneal cavity, and it relies on diffusion of toxins from the bloodstream across the peritoneal membrane into the fluid that's been instilled in the peritoneal cavity, and it can remove toxins this way. It can remove volume this way as well. Okay, and once the solution has sat there for a period of time, and we'll talk about that, it can be then drained out. Okay, and this dialysis is typically performed at home, and there's different ways of performing peritoneal dialysis, and we'll talk about that. Okay, so what's the function of dialysis? Well, it eliminates excess fluid and electrolytes from the body, because if the kidneys aren't performing that role, something has to perform it. Otherwise, the patient's going to become fluid overloaded, and likely hyperkalemic. Okay, so either one of these types of dialysis, hemodialysis or peritoneal dialysis, can perform this function. Maintaining acid-base balance, right? The body is constantly producing acids from metabolic activity. If your kidneys aren't functioning, you're going to become acidotic, which is deadly. And dialysis keeps the acid-base balance between 7.35 and 7.45. Okay, removes metabolic waste from the body. There's a whole bunch of different types of waste products. We measure some of them, such as BUN and creatinine, as kidney markers. Okay, and it maintains overall homeostasis, not hemostasis. That's the process of blood coagulation. Homeostasis, which is the balance, the balancing in the vascular system of the blood, and it does this by diffusion, such as in peritoneal dialysis, osmosis, and filtration. Okay. So what are some reasons for requiring dialysis? Well, someone who has end-stage renal failure. As I mentioned, diabetes, hypertension are common causes of end-stage renal failure. Okay. Someone who's sustained an acute renal injury and the kidneys are no longer functioning may require dialysis. Okay. Sometimes the kidneys can recover from an acute renal injury, and sometimes they don't. Medication toxicity or overdoses. There are some drugs and some overdoses that can be dialyzed out of the patient. Okay, so if someone's taken an overdose, there's too many drugs to go over to mention them, but if someone's taken an overdose of a dialyzable drug, well, one of the best ways to remove the drug before it kills the patient is dialysis. Okay. Someone who has renal failure and is hyperkalemic, we cannot get their potassium down because the kidneys have failed. Well, that is a reason for emergent dialysis. Okay. And another one, again referring to chronic renal failure, typically is hypervolemia. The kidneys can no longer filter and make proper amounts of urine, so the fluid is building up in the vascular system, and they're becoming hypervolemic, swollen legs, shortness of breath from pulmonary edema. And we'll try diuretics first to try and force the kidneys to make urine, but that doesn't always work, and they need to head to dialysis. Okay, so this slide's a bit repetitive. So you have to lose a significant amount of your nephron function um, for your kidneys to really start to fail. So look at 80% of your nephrons need to be non-functional. And I would say the most common reason for dialysis is chronic renal failure, okay? Where patients will now permanently be on some form of dialysis. And typically the reason that they start dialysis um, is hyperkalemia, okay, or metabolic acidosis, or fluid overload, okay? Fluid overload causing pulmonary edema. Now, if a patient has chronic renal failure, often we don't wait for them to develop hyperkalemia, fluid overload, and metabolic acidosis. We know that's the direction they're heading, and preparations are made for dialysis before one of these dangerous events occur. Okay. Just remember that a liter of water or fluid weighs about a kilogram in terms of weight, and a kilogram is 2.2 pounds. Okay. So what's the goal of dialysis? Well, to remove toxins, to remove excessive electrolytes, and to remove fluid. Okay. And we're going to talk about three types. Hemodialysis being the most common, and then peritoneal dialysis being a bit more convenient since you can do it at home, and another one called continuous renal replacement therapy. Okay. Okay, so let's talk about hemodialysis first, where we are going to directly access an AV fistula, which, as I mentioned, is typically in the arm, where a large artery has been connected to a large vein, and there's lots of blood flow through that connection. Okay, and this is a surgical procedure. And if you were to look at an AV fistula, you would often either hear a bruit with that rapid blood flow going through it, or if you put your fingers on it, you would feel the blood flowing with what's called a palpable thrill. Okay, because there's just so much blood that's flowing through the AV fistula. That's why it was created. Okay. Remember, when someone has an AV fistula, not to do procedures on that arm, such as blood pressure checks, administering injections, putting in an IV line, anything like that. We want to avoid that arm because there's an AV fistula there, and we don't want to cause any issues with the AV fistula. Okay. As I mentioned, hemodialysis is usually 3 times a week. So they have a schedule, and it's usually around 3 to 4 hours. Okay, and it involves the insertion of 2 needles, one into the artery and one into the vein to return the blood. So one to take the blood and one to return the blood. So during the procedure of hemodialysis, the system is being monitored, the patient is being monitored. So the dialysis circuit, where in the machine, is being checked for blood clotting, air bubbles, the temperature of the dialysate. And sometimes the patient can become hypotensive. If too much fluid is being taken off, they can become hypotensive, right? There can be bleeding at the access site, at the AV fistula. So that needs to be monitored. So the patient is going to receive, or is going to have, vital signs and also coagulation studies taken during the procedure. The dialysate machine is administering heparin. Okay, so heparin is an anticoagulant, and it's to avoid any clotting during the procedure, during the hemodialysis. Okay, protamine sulfate is the reversal agent for heparin if someone is bleeding profusely from a heparin infusion, whether it's for peritoneal whether it's for hemodialysis or just heparin for any condition. Protamine is the reversal agent. Okay. Okay, so after the procedure, vital signs are needed. BUN, creatinine, electrolytes are definitely going to be checked, and your CBC, right? And we expect a decrease in blood pressure because volume's been taken off, and typically we see a BUN and creatinine that's decreased, and if potassium was elevated a bit prior to the dialysis, then it should have been corrected following the dialysis. Okay. Weight is checked so that we know how much volume has been taken off. Okay, so just imagine this machine is not only taking volume off the patient, it's altering electrolyte levels in the system as well. So, and it's also administering some heparin. So if you think about these complications, they'll make sense. Hypotension from the volume removal. Muscle cramps, again, from the adjustment of electrolytes such as potassium. Bleeding because of the heparin that's been instilled. Okay, so there's a lot of things that can happen during dialysis. Okay, and we'll talk about some of the complications coming up. Okay, so this is just an image of hemodialysis. So on the right, the image is showing the blue blood being removed. Okay, and going through the hemodialysis unit. There's heparin being instilled in this system to prevent any blood clotting. And once it goes through the dialysis filtration, where diffusion has occurred, osmosis, and ultrafiltration, it comes back into the patient as clean blood. Okay, so let's just briefly discuss some client education before we get to complications. So we're going to talk when we get to complications in terms of disequilibrium syndrome, which includes nausea and headaches. Remember, all these fluid shifts that are occurring during dialysis and electrolyte changes, people don't always feel well after having dialysis. It takes a bit of time. Okay. So now, after dialysis, it's also really important to check the access site, that AV fistula, okay, for any oozing of blood, for any signs of infection, because that fistula is really important. That's how they're going to get dialysis 3 times a week, right? So you should always feel a thrill when you touch it, and that's the flowing of blood. You may even hear a bruit, which again is the flowing of blood, and that's normal. Okay. Also advising the patient to take folate. Folic acid can become depleted while on dialysis, so some patients need to take folic acid replacement and have foods that are high in folate. Okay. Avoiding, so that arm that has the fistula needs to be protected. You do not want to injure that fistula. Okay, so lifting heavy objects, carrying or compressing, so carrying objects that might compress the fistula, not a good idea. Okay, tight constrictive bandages around the fistula wouldn't be good for the fistula. Okay, so now let's go and look at some complications of hemodialysis. So the first one is clotting and infections. Okay, so you can develop infections at the access site. So with insertion of the hemodialysis needles, not only can it hemorrhage at the site, but you can also introduce infection. Okay, so think of both of those when you're dealing with an AV fistula. The risk of bleeding, and remember, they're also getting anticoagulants while they're receiving hemodialysis, right? So that's going to increase the risk of hemorrhage. And of course, whenever you puncture the skin, there's a risk of infection. So it's really important to have aseptic technique, right? During insertion of the needles for hemodialysis, right? Avoiding any compression of that access site, okay? Because it's basically an artery that's connecting to a vein, and you do not want to injure it, okay? I mentioned the fact blood pressure measurements, IV punctures, IV lines are avoided on that side, on that extremity, okay? And of course, monitoring for redness, swelling, discharge, or fevers. And if that was the case, if we thought that it was an infection at the site, well, they're going to need either oral or IV antibiotics, right? Okay, so let's move on to another one. So hypotension. So this really has to do with the removal of fluid from the intravascular system during dialysis, okay? And this is not uncommon either. Patients can sometimes leave dialysis with significantly lower blood pressure. So sometimes we need to carefully replace some of the fluids with IV fluids, okay? And the other strategy is to slow down the dialysis exchange rate, allow the body to get used to the changes in volume, okay? If someone were to become hypotensive, sure, we might give them IV normal saline. We'd lower the head of the bed so that they're less symptomatic. And if they're severely hypotensive during dialysis, we may need to stop the dialysis temporarily, okay? So anemia is already common in patients with renal failure, right? Because of lack of erythropoietin. It can be magnified with hemodialysis from some potential blood loss and also removal of folate during dialysis. So how can we treat this? Well, in chronic renal failure, patients are often receiving erythropoietin, whether they're on dialysis or not, because there's just not enough of the hormone to stimulate red blood cell production. Also, monitoring CBC to make sure that they're not getting profoundly anemic. Usually we transfuse at around a hemoglobin of 7, okay? Unless someone is really symptomatic. So typically around 7 to 8, we consider blood transfusions, okay? What else can I say about that? I think that's enough on anemia. So let's go to disequilibrium syndrome. So this can occur for a couple of reasons, and it's after hemodialysis, and it's due to really a decrease in circulating fluid volume and all the fluid shifts that occur. And because there's changes in electrolytes and fluid shifts, it can result in some fluids going into the brain, causing some mild cerebral edema and potentially some mild increased intracranial pressure, okay? So typically patients will present with symptoms of headache, nausea, vomiting, decreased level of consciousness potentially, and in some circumstances, seizures can occur as well, okay? And again, the treatment for this is just to slow down the dialysis exchange rate, okay? Because that's going to allow the body to accommodate for the changes in electrolytes and the changes in fluid volume over a longer period of time, okay? If someone has a history of developing seizures while taking dialysis because of disequilibrium syndrome, sometimes they'll need an anticonvulsant. Okay, so let's look at peritoneal dialysis. So the other form of dialysis, and this involves having a, a catheter inserted into the peritoneal cavity that can be instilled with dialysate, which is a very hypertonic solution that will sit for a period of time, which is called a dwell time, in the peritoneal cavity. And what happens is, because the dialysate solution is hypertonic, it's going to draw toxins and volume out of the bloodstream and into the peritoneal cavity. Okay, so I think that's pretty amazing. Okay, so so it sits there for a certain period of time, and then the patient drains the fluid out. Okay, so so who is this good for? Well, patients who cannot take anticoagulants because of bleeding disorders, so they should avoid hemodialysis. They would be a candidate for peritoneal dialysis. A patient that has a very difficult vascular access, which is needed. Remember that AV fistula? So if they don't have a good vascular access, peritoneal dialysis would be good. Patients who have multiple chronic illnesses, diabetes, heart failure, all kinds of illnesses that they're managing with an assortment of medications that the dialysis machine may end up removing, but also it would make it extremely difficult to get to hemodialysis 3 times a week. Okay. So let's just talk about the procedure a bit. So typically, the nurse will check the weight of the patient without any dialysate on board, vital signs, blood electrolytes, BUN and creatinine, and a serum glucose. Okay, so just some pre-dialysis blood work and the weight of the patient. And the patient needs to have a certain degree of dexterity to perform peritoneal dialysis, and also to do it with sterile technique, right? So the patient has to be fully alert. They have to have some previous experience with dialysis and a really good understanding of the procedure, okay? Because you don't want to break aseptic technique, right? So the dialysate solution is instilled, and when it's instilled, the abdomen is a bit distended, right? So during that dwell time, there's a fullness that can be felt to the abdomen, and for some people, it can be a bit uncomfortable. Okay. So there's a couple of ways of performing peritoneal dialysis, and we'll talk about that on an upcoming slide. Okay, so this image is just showing you that there's a catheter that's inserted through the abdominal wall, and it sits in the peritoneal cavity. Okay, so you can already imagine one of the complications of peritoneal dialysis is going to be peritonitis. We'll come to that. The dialysate solution is instilled, okay, and depending on which regimen that we're going to talk about the patient is following, it'll sit in there for a certain number of hours, and then the dialysate can be removed, right? So, and while it's sitting in the peritoneal cavity, it's by diffusion allowing toxins to come into the dialysate. It's equilibrating electrolytes. It's pulling some volume out of the bloodstream. So it's doing actions that are very similar to hemodialysis, but in a much more passive way, just with this fluid sitting in the abdomen. Okay. Okay, so let's look at the image on the right for the different ways of administering peritoneal dialysis. So the first one is continuous ambulatory peritoneal dialysis, so CAPD, and this is every day. And so the patient will instill the dialysate, say at 7 o'clock in the morning, empty it at noon, and shortly after put in fresh dialysate solution, and this just continues throughout the day. And then at bedtime, you put one in that will last throughout the night, right? So really, it's continually happening, okay, every day of the week, okay. And while the dialysis is in the peritoneal cavity, the patient can just continue with their regular activities. Okay, so let's just look at continuous cycle peritoneal dialysis. So this will be the second one down under APD. So basically what's happening is at 10 o'clock at night, an automated machine is going to cycle the peritoneal fluid. Okay, so it's going to exchange all throughout the night while the patient's sleeping. And then in the morning, the last dialysate that goes in stays in for the whole day. Okay, so the dwell time will be from 7 a.m. to 10 p.m. and then they'll go back on and have this continuous cycle of peritoneal dialysis. Okay, so really this one makes the group of which is called automated peritoneal dialysis, which is the cycling that's occurring throughout the night while the patient is sleeping. Okay, and notice that there's different options throughout the day. So the nighttime starting at 10 is all automated, right? So it's continuous cycling, but it's automated throughout the night. They're sleeping while it's happening, which is the orange there. And then throughout the day, there's options. You can leave it in all day, you can leave it in for part of the day, or you can do 2 exchanges through the day. Okay, so just understand what automated peritoneal dialysis is, which is occurring at nighttime. And then the continuous cyclical peritoneal dialysis is, yes, the exchange is still occurring at nighttime, but then there's different variations of what can occur during the day. Okay, image on the left is just showing you how the peritoneal cavity fills with fluid and sits there. And it's the peritoneal membrane that is going to allow toxins. So the peritoneum is very vascular, so there's lots of blood supply, and it's going to allow toxins, BUN, creatinine, electrolytes to diffuse into the dialysate that can then be removed later. Okay, so we spoke about the different types of peritoneal dialysis schedules. Before we get to complications, let's just talk about what's occurring during the procedure. So, what is the nurse doing during this procedure? So, assuming they're in hospital. So, monitoring of vital signs definitely should occur in the hospital. Monitoring of blood sugar. So this is a hyperosmolar solution, so high in dextrose, and it contains glucose. So some of that can go into the bloodstream and cause hyperglycemia. So monitoring of blood sugar. Okay, monitor the amount that goes into the peritoneal cavity versus how much comes out of the peritoneal cavity, and typically the output should be a bit higher than the input, right? Because some of the volume should have come off the vascular system. Monitoring for any signs of infection, so fevers, cloudy dialysate. It should be clear, okay? Any signs of volume overload, such as respiratory distress, okay? Check the access site. Is it red? Is there any discharge? Is there any tenderness around it? Okay, that's important to make sure that it's not getting infected. Always maintain surgical sterility, right? So an aseptic technique for insertion and whenever the catheter is being accessed. Okay, the outflow bag should be lower than the patient's abdomen, because it's going to drain by gravity, okay? And I think we'll go on to procedure to complications. Okay, so complications, peritonitis. Well, that makes sense. We actually have a tube that's going from the abdominal wall into the peritoneal cavity. So there's always going to be a risk for peritonitis. Okay, which is a serious condition, right? Inflammation of the peritoneum, often associated with bacterial infection, creates a cloudy um, dialysate when you're removing it. So that's concerning if you see a cloudy dialysate. Okay. So the key to avoiding this is aseptic technique. Whenever you're dealing with the catheter and watching for any signs of infection. So abdominal pain, that would be concerning in someone with a peritoneal catheter. Fever, purulent discharge, cloudy looking solution, anything like that, okay, would be concerning. Next one is protein loss. So peritoneal dialysis, you can actually lose some protein from the bloodstream into the peritoneal cavity. So you can be a bit deficient in albumin. So albumin levels need to be monitored. And often the patient is encouraged to increase dietary protein when they're on peritoneal dialysis because of the loss of protein, which is a bit counterintuitive because with a, quote, renal diet, it should be low sodium so that you don't drink more fluids and get fluid overloaded, low phosphorus because you tend to have a high phosphate in renal failure. Remember, because parathyroid hormone is actively breaking down calcium and phosphate from the bones. So you have an elevated serum phosphate. So you don't want to eat more phosphate. And a low protein diet. Okay. With peritoneal dialysis, it's encouraged to increase protein a bit to maintain albumin levels. Okay. Okay, so the next one is hyperglycemia, which I mentioned can occur because the dialysate solution is hyperosmolar with glucose within it. So some of that can go into the bloodstream and cause hyperglycemia. We don't really know why hyperlipidemia occurs with peritoneal dialysis, so I can't give you a good explanation for that, but definitely people become hyperlipidemic, which can increase their risk of cardiovascular disease. Okay, so monitoring of blood glucose is important. Some patients may require insulin to get their blood sugar under control, and monitoring of cholesterol levels and potentially treatment with cholesterol lowering medications. Okay. The next one is poor dialysate flow. So this can occur from a twisting or obstruction of the tube itself, so the catheter. Constipation, because constipation within the colon can put pressure on the catheter that's within the peritoneal cavity, right? The way the client is positioned can obstruct the catheter. We mentioned obstruction. That can be from a fibrin clot within the catheter itself. And unfortunately, if the catheter has been displaced. Okay, hopefully not. So what can be done? Well, repositioning of the client to see if that's going to help with the flow. Milking the tube to try and break up any fibrin clots which is within the catheter. Okay, and also looking for any kinks or twists in the catheter as well. Okay. Another important aspect is preventing constipation with diet and stool softeners. Okay, and that's going to prevent poor dialysate flow. Okay, so the last one is infection at the access site itself. So that can be caused from some seepage or leakage of dialysate around the access site. And access site infections can go inwards and cause peritonitis. Okay, so which can of course be very serious. So again, it's that aseptic technique when you're dealing with the catheter site, looking for any signs of infection around the catheter site, the redness, discharge, swelling, or any fevers. Okay, and I think that is it for this slide. Okay, so let's do the questions at the end of chapter 57. A nurse is teaching a client who has chronic kidney disease and is to begin hemodialysis. Okay, which of the following information should the nurse include in the teaching? So this is just a select one. So A, hemodialysis restores kidney function? Absolutely not. It doesn't. It replaces some of the kidney functions, but it doesn't restore kidney function at all. Hemodialysis replaces hormonal function of the renal system. It definitely doesn't. It doesn't replace production of erythropoietin, and it certainly doesn't convert inactive vitamin D to active vitamin D. Okay. Hemodialysis allows an unrestricted diet. Definitely not. Patients still need to be on a renal diet. If they're consuming large amounts of salt, they're going to drink more and become fluid overloaded. They already have potentially high phosphate levels, so they have to be on a low phosphate diet. So there's fluid constraints, there's salt constraints, so it's not an unrestricted diet at all. D, hemodialysis returns a balance to blood electrolytes. Absolutely, right? So if you were to not have hemodialysis, or if you missed multiple appointments for hemodialysis, you're going to become hyperkalemic, and that can lead to serious arrhythmias and even cardiac arrest. Okay, so the answer is D. Number 2, a nurse is preparing to initiate hemodialysis for a client who has acute kidney injury. Which of the following actions should the nurse take? Okay, so there's 6 answers here. So review the medications the client currently takes. Yes, that's very reasonable, right? A lot of medications are dialyzed off, right? So taking your medication just before dialysis, it might be just removed by hemodialysis. Okay, so reviewing the medications is important. Assess the AV fistula for a buoy, for sure, right? You need to check that blood is flowing nicely in the AV fistula. Calculate the client's hourly urine output. I don't know why you would have to do that at all. Some patients don't make any urine at all with renal failure. Others might make just a little bit of urine throughout the day. Okay, so everybody's different. That's not going to be important at all. Measure the client's weight. Absolutely. Measure the client's weight before and after, because that tells you how much fluid has been taken off. Check blood electrolytes. Absolutely. To see where you're starting. Use the access site area for a venipuncture. Never, right? Don't use that arm for blood pressure checks, IV access, and definitely you wouldn't use the access site for a venipuncture. Not at all. Okay, so it's A, B, D, and E is number 2. 3, a nurse is planning a post-procedure care for a client who received hemodialysis. Which of the following interventions should the nurse include in the plan of care? Okay. Check BUN and blood creatinine after receiving hemodialysis. Sure, that's reasonable. Administer medications the nurse withheld prior to dialysis. Absolutely. I mentioned that some drugs are dialyzed off, so there's no sense in taking them before the dialysis. They can be taken after the dialysis. So that's correct. Observed for findings of hypovolemia. Absolutely. If hemodialysis removes too much volume, the patient can be hypotensive. They can be, they can have significant volume shifts. They can have orthostatic hypotension because they're hypovolemic. Assess the access site for bleeding. Definitely. Remember, this is an artery that's connecting to a vein, and we want to make sure that there's no bleeding there. Evaluate blood pressure on the arm with the AV fistula. Definitely not. So it's A, B, C, and D. 4. A nurse is caring for a client who develops disequilibrium syndrome after receiving hemodialysis. Which of the following actions should the nurse take? Okay, so disequilibrium syndrome is where there's potentially a bit of cerebral edema, a bit of brain swelling because of the fluid shifts. So I'm thinking if there's some fluid in the brain or a bit more causing cerebral edema, headaches, nausea, vomiting, off balance. Okay, those are symptoms coming from the brain. Okay, and of course, level of consciousness. So administer an opioid medication is the first answer. No. Monitor for hypotension. No. People usually have hypotension after hemodialysis, and it's not related to disequilibrium syndrome. Assess level of consciousness. There it is. Okay, that's going to be the answer. So C. D. Increase the dialysis exchange rate. No, you want to slow it down so the volume shifts are slower and not as abrupt for the patient. Okay, last question, number 5. A nurse is planning care for a client who will undergo peritoneal dialysis. Which of the following actions should the nurse take? Monitor blood glucose levels? Absolutely, right? Glucose can go from the dialysate solution into the bloodstream and cause them to be hyperglycemic. Report cloudy dialysate return. Definitely. That can be an indication of infection, peritonitis. Warm the dialysate in a microwave oven. I certainly hope not. Okay, I don't think that would be an accurate way of warming dialysate solution. D. Assess for shortness of breath. Yes, right? It's important to assess for shortness of breath. When we're putting in a significant volume of dialysate solution, we're distending the abdomen, and that can make it harder for the diaphragms to go down, and that can result in shortness of breath, right? So it's just a matter of finding out whether the person's comfortable enough with the dialysate solution in their peritoneal cavity. Check the access site for dressing for wetness. Definitely. The discharge or the leaking of dialysate solution at the access site can result in infection, and if it goes deeper, it can result in peritonitis. Maintain medical asepsis when accessing the catheter insertion site. And this one, I think, is a bit of an unfair question. They're looking for surgical asepsis versus medical asepsis. Okay, so I got caught on the word. So it should be maintain surgical asepsis when accessing the catheter insertion site. So the answer is A, B, D, and E. Okay, let's go on. Okay, so let's just briefly talk about continuous renal replacement therapy. It's just another form or another way to clean the blood. Okay, so we've spoken about hemodialysis and peritoneal dialysis. This form still accesses the bloodstream, but it can be used for a short period of time in someone who's critically ill. Okay, someone who has very unstable vital signs. For example, they're hypotensive from being septic, and they've developed acute kidney injury, and their kidneys are malfunctioning, but the blood still needs to be cleaned, right? So this form of therapy can be for a short period of time. So they can provide this therapy through a central line, or if the person happens to have an AV fistula it can temporarily be used through there. Okay, so think of this therapy as someone who's really unwell, and their kidneys have failed and they need interim dialysis. Okay. Um, Now, what are the complications of this? Well, the idea behind this therapy is it's much slower than hemodialysis, which is over 3 or 4 hours, 3 times a week. This runs very slowly over 24 hours, since the patient is critically ill. And by doing that, it reduces the fluid shifts and the massive changes that occur in electrolytes during hemodialysis. Okay, so it's a bit safer to use in someone who has very unstable vital signs. Okay, so that's the idea behind it, to do it very slow over 24 hours instead of 3 or 4 hours with hemodialysis. So the complications are pretty similar to hemodialysis. Sure, you can develop infection. Anticoagulation. Well, because the blood is flowing through this machine very slowly, there's a much higher risk of clotting of the blood. So significantly more anticoagulation is required to stop the blood from clotting in the machine. Okay, and that anticoagulation goes to the patient. So they are at higher risk for bleeding because of it. Okay, and you can still get hypotension with this therapy, but it tends to not cause the same degree of hypotension compared to hemodialysis. So I would think of it as just a gentler form of hemodialysis that spans 24 hours in a critically unstable patient that needs dialysis because their kidneys have failed acutely. Okay, so let's move on to kidney transplantation. So this is a relatively common organ transplant because kidney failure is relatively common, right? So the most common causes of chronic renal failure that would put someone on a transplantation list is diabetes and hypertension. Those are the two most common causes of chronic renal failure. There's definitely other causes, for example, diseases that directly attack the kidneys, such as glomerulonephritis. Lupus, for example, can cause glomerulonephritis, leading to renal failure, and many other diseases. But the two main ones, diabetes and hypertension. So kidney transplant, the recipient needs to be matched to the donor, right? So not just any kidney can be inserted into a patient. There has to be matching of the blood type, so ABO compatibility, and also to get what's called the histocompatibility very close. Okay, so on the kidney, there's antigens just like anywhere else in the body, and if it's a close match in terms of histocompatibility, the less chance there will be for organ rejection. Okay, so for example, a donor kidney coming from a relative would have a much better chance of having a similar histocompatibility compared to a complete stranger. Okay, so ABO compatibility, so the blood types have to be the same, and also the HLA compatibility, so human leukocyte antigen. That's how they assess for how similar the donor kidney is to the patient's tissue type. So the recipient of the kidney can get it from a living donor. It can be from a patient that has recently died, but the kidneys are still being properly perfused, right? So remember, these kidneys that are being donated have to still have some perfusion to them. Otherwise, the kidney won't survive and won't be appropriate for transplantation. Okay, and kidneys, as you'll see, are transplanted in the pelvis. They aren't transplanted where the original kidney was. Okay, and I'll show you an image of that. So why would we, what are indications for a kidney transplant? Well, let's make it simple. They're unable to cleanse their blood anymore, so they can develop toxic buildup in their bloodstream. They can develop fluid overload because the kidneys aren't filtering anymore. They can develop hyperkalemia, which is deadly to the heart, leading to cardiac arrhythmias. Okay, so I usually think of it as electrolyte issues, fluid overload, inability to clear waste from the bloodstream. Okay. There's a long list in chapter 58 on clinical presentation, expected findings of end-stage kidney disease. Let's just go through that long list and explain why they have those symptoms. So first one, so it's on page 385. First one, anorexia. Well, they have circulating waste. They're anorexic. Fatigue. They're anemic because they don't make erythropoietin properly anymore. So they have chronic fatigue. Plus, they have waste in their bloodstream, so they're tired from it. Okay. Numbness and tingling of extremities. Well, this waste is affecting the peripheral nerves and causing them to have some peripheral neuropathy. Shortness of breath, volume overload. Dry, itchy skin, very common in end-stage renal disease, and it's from the toxic buildup of waste. Okay, that's also affecting the skin. Muscle cramping, that's from electrolyte abnormalities. Okay, decreased attention span, that's from the toxic waste now affecting the brain. We use the term uremic. So uremic is just a medical term to say I have toxic buildup of waste such as BUN and creatinine in my bloodstream. I am uremic. Okay. Seizures can occur from fluid buildup in the brain, but also electrolyte abnormalities. Okay. Tremors. Okay, sure, tremors can occur. Tremors are more common in a specific type of tremor, is more common in liver failure, where you get what's called a liver flap. Okay, I would say it's more common there. Heart failure, absolutely. Most patients with chronic renal failure, the number one cause of death is heart failure. Okay, so they get fluid overloaded, but also chronic renal failure causes significant strain on the heart, leading to death. Edema of the hands and feet, that's just the kidneys unable to filter blood properly and produce appropriate amount of urine. So they're fluid overloaded. Dyspnea, fluid overloaded. Distended jugular neck veins, fluid overloaded. Anemia, lack of erythropoietin. Vomiting, because they have toxins in their bloodstream. Pulmonary edema, fluid overloaded. Hypertension, fluid overloaded. Cardiac arrhythmias, hyperkalemia. Pallor, anemia from lack of erythropoietin. Bruising, because they have all this waste circulating in their bloodstream, and it affects the clotting factors, and it causes them to be much more prone to bruising. Okay, so just think of all this waste in the bloodstream, and the body just can't perform its normal functions with all this waste. Okay, halitosis, which is bad breath, again, toxic. So you can have so because you're uremic, you have a certain odor on your breath. Okay, and typically as your kidneys are failing, the last one, diminished urine output. And some patients that are on dialysis either don't make any urine at all in every day in 24 hours, or they just make a little bit of urine. But if you're on hemodialysis or peritoneal dialysis, we don't really care how much urine you make anymore, okay? Because that's not your primary way to cleanse the blood, okay? So those are clinical presentations before dialysis, by the way. Laboratory data, okay, well, what's happening with the kidney? It's failing. So the glomeruli are going to become leaky. They're going to leak protein into the urine, going to leak blood into the urine. The toxins are building up in their bloodstream, so BUN and creatinine are building. The GFR is definitely going to be very low, okay, because the kidneys are unable to do their proper filtration. Decreased hemoglobin, absolutely. It's almost universal in chronic renal failure because of lack of erythropoietin stimulating the bone marrow. Elevated potassium, they can't clear the potassium from their bloodstream, so it starts to go up, and that can be dangerous. Elevated phosphorus levels, remember, the phosphorus is coming because of the bone breakdown. Okay, why is the bone breaking down? Because the kidneys aren't making vitamin D, so the patient can't reabsorb calcium from the gastrointestinal tract, and that causes a slightly lower calcium level, leading to parathyroid hormone to start breaking down bone. And when you break down bone, sure, you control your serum calcium level, but you get excessive phosphorus. Okay. Sodium can be anywhere. It can be normal, it can be decreased, it can be increased, so I wouldn't spend too much time on that one. Metabolic acidosis, absolutely. The kidneys are responsible for clearing H+, which is acid, and as I mentioned before, they are responsible for making large amounts of bicarbonate to buffer the blood to prevent metabolic acidosis. Okay. Okay, I don't think I need to spend too much time on this slide. So kidney transplant information. Okay, so who can donate a kidney? Where can the kidney come from? So from a living donor, it could be a family member, which is going to have the closest histocompatibility matching and ABO blood type matching. But if that's not available, it could come from another living donor. Okay, cadaver donation is someone who's recently deceased. So say someone was in a car accident and they were declared dead or brain dead, for example, and there's still perfusion to the kidney. Well, that kidney can be harvested for donation. Okay, non-heart beating would be the least common. And remember, the kidney still has to be relatively fresh. It has to still be perfused. So when I see the term non-heart beating, I'm thinking of someone who's died and they've had a non-beating heart for a long time. That wouldn't be the case. Okay. Now there are tissues in the body that can be donated that don't require the patient to have a beating heart, or the patient that's brain dead. That would be a cadaver, by the way. That can be their tissues can still be donated, such as the cornea. Tissue valves can be donated, but kidneys need to be perfused, otherwise they will die. So non-heart beating donation is being used, but remember, it has to be very recent in terms of non-heart beating. Okay, so let me just clarify that. So if you're brain dead because of an accident, you're declared brain dead, but your heart is still beating. Okay, well, your kidneys are being perfused, so they have potential to be donated. Because of the high demand of kidneys for transplantation, non-heart beating is someone who's recently died and doesn't have a beating heart, but the tissue, the kidney, is still potentially viable. Okay. The matching of blood, so ABO compatibility, so the blood type of the donor kidney, and remember the HLA histocompatibility. So the closer the match, the less chance of organ rejection. Okay. So really, the best results come from a living donor who's related. Okay. Okay. So when anyone is having an organ transplant, they're going to be on lifelong immunosuppression. So whether it's the heart or the kidney, it's lifelong immunosuppression with medications. So what's that going to cause in that patient? Well, it's going to allow them to have a donor kidney, which is the positive aspect of it, so that they don't have to be on hemodialysis or peritoneal dialysis. So that's the advantage of being on immunosuppression. The disadvantage is lifelong risk of infections any day. Okay, so patients that receive organ transplants are made very aware of symptoms of infection. So fevers, infectious symptoms such as a cough, sore throat, anything that can develop into overwhelming infection, okay, because they're so immunosuppressed. The other information they're provided is that there's a lifetime increased risk of developing certain cancers. For example, lymphomas, which are cancers of the lymph tissue. The immune system is responsible for monitoring for any cancer development in the body. So if we immunosuppress the patient, not only are they at risk for infections, they're at risk for developing cancerous cells over years. Okay. Another consideration is possible rejection. So there's always a risk that the kidney will be rejected. And that's why ABO compatibility and HLA compatibility is looked at closely prior to the transplantation. Okay. So that patients don't develop acute kidney rejection or even chronic kidney rejection, which can still occur. Okay. What about contraindications to a kidney transplant? So I would say the main contraindications are active cancer, um, a patient who is likely going to be completely non-adherent to their medications, meaning the immunosuppressive drugs, someone who has significant heart disease or lung disease that they may not survive the surgery to begin with. Okay, so nobody wants to insert a kidney only to see it not survive. So they're trying to increase success. Okay, so active cancer, high risk of non-adherence to medications, and severe heart disease where the surgery may not be survivable. Okay. Now, are there other considerations when a kidney transplant is being done? Sure. If you're very, very young or very, very old, for example, okay, you're at higher risk for complications when you're old, but it's not an absolute contraindication. Okay, so many patients that are having kidney transplants are easily over the age of 65. So now, a patient who has severe heart disease, where they think, after a consultation with an internist, for example, where they think, well, no, this person will not survive this surgery. Okay, then they won't do it. Okay. I mentioned active cancer as a contraindication. Chemical dependency. So somebody who the kidney will likely not survive because of their addiction. That could be a contraindication. Someone who has active infection that is just unable to clear. So say, for example, someone has osteomyelitis and they just can't clear it. Chronic osteomyelitis. Well, that may be a reason why they wouldn't want to put in, they wouldn't want to transplant a kidney. Okay. The other ones on the list that you'll see in your book under considerations for kidney transplantation would be more, they would just be considerations that would potentially alter the risk of the transplantation as opposed to not doing it at all. Okay, and you'll see on this slide, so cardiac considerations, bleeding, so coagulation. I mentioned so active cancer would be an absolute contraindication. Pulmonary disease, so someone with severe COPD who may not get off the ventilator. Someone with morbid obesity where the surgery would be extremely difficult and they're prone to all kinds of complications. They may opt not to do the surgery. Okay, so a lot of these that you'll see in your book are relative contraindications. They're not absolute contraindications. Okay, so let's just look at the image here for kidney transplantation. The old kidneys are left in place, right? So a patient that's receiving a donor kidney because of chronic renal failure, say from diabetes or hypertension or glomerulonephritis, whatever caused their original kidneys to fail, those kidneys are left in place unless there's a good reason to surgically remove them, such as they're developing chronic recurrent infections. Okay, the kidney can be removed. Or they're causing resistant hypertension, then they can be removed. Otherwise, they're just typically left in place. And the donor kidney is inserted in the pelvis, right on the inside part of the iliac crest. Okay, so so they're never replaced where the original kidneys are, since they're still there. They're put in the pelvis. A blood supply is created from the iliac artery, and of course, there's a venous drainage to the iliac vein, and a ureter connects to the bladder. Okay. In terms of post-procedure care after someone's received a kidney transplantation, it's very well laid out in the book. So I'm not going to go over it here. Just to remember, anyone who's post-surgical will need their vital signs taken frequently, typically every 15 minutes initially, and then hourly after that. Urine output for this particular surgery is very important. At least 30 milliliters per hour is expected. If the urine flow were to go down, that would be a concern, right, for either hyperacute rejection, maybe blockage of a renal artery during the surgery, or maybe the ureter's blocked. Something has happened. Okay, so really monitoring of the urine output is important. There's a number of other parameters that are monitored, such as fluid and electrolytes. Well, that makes sense. There's a new kidney that's doing the filtering for the entire body. So we want to see that it's properly filtering potassium and maintaining normal sodium levels, right? Daily weight's really important because the kidney is so involved in fluid regulation. Monitoring for any post-surgical infection, really important, okay? And also monitoring for organ rejection, right? And that would be in the form of fevers, decreased urine output, hypertension. It could be an indication that the kidney is just not functioning normal. Okay. So there's other ones that are listed in your book. I think I'll leave those because I think that they're clearly marked out. Okay, so some of this information is on this slide is on pre-op and some's on post-op. Okay, so Laboratories, well, that's going to be pre-op, right? So a basic metabolic panel, so electrolytes, BUN, creatinine, uh, they're all done preoperatively. CBC, pre-op. Coagulation studies, we want to know that the patient is coagulating properly before going under the knife, right? Um, those are always checked preoperatively. Urinalysis, urine culture, just to rule out any infection, and a type and cross match in case the patient has significant bleeding and blood needs to be rapidly accessed from the blood bank. Okay. In terms of medications, well, prophylactic antibiotics are often used prior to renal transplantation. Patients with renal failure are immunosuppressed. All these toxins that are circulating in their bloodstream really suppresses the immune system and the bone marrow. So we consider patients that have chronic renal failure to be immunosuppressed. So they get prophylactic antibiotics prior to the surgery. They're also given immunosuppression just before the surgery. Okay, so there's a number of medications such as corticosteroids that suppress the immune system, cyclosporin, azathioprine, and there's a monoclonal antibody called basiliximab that can also be used just prior to the surgery to prevent organ rejection. Okay, so the body has to be a bit immunosuppressed prior to the surgery, otherwise there's a good chance the body will react to the new organ and attack it. Okay, post-operatively, they are typically on immunosuppression now for life, right? So let's look at some of the medications. So, so corticosteroids can be used post-operatively. So methylprednisolone is an intravenous form of corticosteroids. Prednisone would be the oral equivalent. Cyclosporin is a medication that a patient will typically remain on, okay, for long-term immunosuppression. Okay, so when you see patients on cyclosporin, often it'll be for immunosuppression related to their renal transplantation. Now, another important aspect to this is the patient will be counseled on how they're feeling about the surgery. Are they mentally and emotionally prepared for the surgery? But also adherence to medications following the surgery. That lifelong immunosuppression is critical to the survival of the donor kidney, and also other aspects of the treatment. So smoking cessation. Smoking is really hard on kidneys because it reduces oxygenation within the blood, so it increases the chance of organ rejection. Proper control of blood pressure, and often these are diabetics, so proper control of blood glucose will be needed lifelong, right, to protect the kidney transplant. So these patients are going to need a lot of follow-up for control of their other illnesses, such as hypertension and diabetes. Okay. Okay, so this slide just goes through post-op kidney transplantation monitoring. So I think most of them will make sense. So after someone's had the kidney implanted, monitoring of fluid and electrolyte balance in the body. Okay, so they're going to have frequent electrolytes drawn, looking at sodium and in particular potassium, to see that the new kidney is actually functioning and controlling these electrolytes in the serum. Okay. Also, is the kidney controlling the volume of fluid in the body? So daily weights is important. Initially, after the surgery, monitoring vital signs very frequently, every 15 minutes, because they've had a new organ implanted and there's a risk for hemorrhaging. and shock, right? So we want to get on that quickly if that were to occur. So frequent vital signs at the post-operatively. Assessing input and output. So the output, that urine output, is really important. At least at a minimum 30 mils per hour. Okay, on average, a human should be making about 1 to 2 milliliters per kilogram of weight per hour. So if you're 70 kilograms, you should be making about 70 to 140 milliliters of urine per hour. Okay, but 30 milliliters is the cutoff in terms of what we're happy with. So below 30 milliliters would be concerning for sure. Okay. Fluid replacement. So this patient's had significant surgery. They likely have a paralytic ileus. So they're going to be maintained on intravenous fluids, typically Ringer's lactate or normal 0.9% normal saline, until we can hear bowel sounds returning. And when we hear bowel sounds, it means that the paralytic ileus is resolving and they can start clear fluids. Okay. Monitoring for organ rejection, that's going to be fevers, right? If an organ's being rejected, there's a lot of inflammation, so it's going to generate fever. Hypertension will be an indication that the kidney's no longer regulating volume, leading to hypertension. And pain at the surgical site, okay, within the surgical site, meaning that kidney is being attacked. Okay, dressing changes. Looking for signs of infection, redness, discharge, swelling. Is there a collection of blood at the surgical site called a hematoma? Okay. Monitoring for abdominal distension and paralytic ileus. Well, I mentioned that, and we do that through symptoms. So is the patient distended, meaning there's nothing flowing in the gastrointestinal tract? Do they potentially need an NG tube because of the paralytic ileus? Do they have bowel sounds yet? Often with paralytic ileus, there's absolutely no bowel sounds. Okay. Remember, paralytic ileus is not a mechanical obstruction. It's just that the bowel has turned off temporarily because of the stress from the surgery. Okay. One that's not mentioned here is administration of immunosuppressive drugs. That's going to be critical. So whether it's corticosteroids or cyclosporin or basiliximab, those definitely need to be given in a timely fashion for organ rejection, right? Monitoring for potential infections. So we're going to monitor not only white blood cell count, but also any signs of infection, and also check white blood cell count for potential elevation, which would be an indication that there could be an infection. As for other surgical complications, we're going to monitor for DVTs. So deep vein thrombosis, this person is going to be immobilized for a short period of time. So do they have a swollen leg? Do they have a red, tender, swollen leg? Okay. If a DVT developed and a piece broke off and traveled to the lung, that would cause a pulmonary embolus. Are they acutely short of breath? Did they become acutely hypoxic? Do they have pleuritic chest pain? Okay, those would be indications that would concern us for a PE. Managing constipation, right? This patient's going to be immobile, not drinking very much. So administration of stool softeners when they're able to take oral medications, and treatment of constipation if needed. And this is really to prevent any straining because they've had a surgical procedure. Okay, so what happens if the urine output does start to drop below 30 mils per hour? What can be done? Well, I mean, typically the transplant team would need to be contacted, right? Because they have oliguria. And sometimes the kidney just needs waking up, just a bit of stimulation with diuretics, for example. Okay, so mannitol is a very strong diuretic, so that could be administered to try and get the kidneys to wake up and start flowing with urine. Okay. There's other diuretics such as thiazide diuretics, the common one being hydrochlorothiazide, or a loop diuretic such as furosemide. But mannitol tends to draw a lot of fluid into the kidneys, so it would be used to try and wake up the kidney post-surgical. Okay. Always remember that diuretics drain patients of fluid, so they can result in not only electrolyte abnormalities, but also hypertension. So let's look at some complications of kidney transplantation. So first one, organ rejection, right? And it comes in uh, three forms. So hyperacute rejection typically occurs within the first few days, and it's immune mediated, right? So the body is directly attacking the transplanted kidney and causing blood vessels to occlude and clot, and it's going to result in um, kidney rejection. So that kidney needs to be removed. Okay. The symptoms typically are fever due to all the inflammation that's occurring, uh, hypertension due to lack of volume control from the failing kidney, and pain at the surgical transplant site. Okay. Acute rejection is typically 1 week to up to 2 years, where, so again, it's an antibody-mediated response causing damage to the blood vessels that are supplying the kidney, leading to gradual kidney destruction. Okay. And how are they going to present between that 1 week and 2 year mark? Well, decreased urine output to the point of anuria, which is no urine output, fevers, poor volume control, leading to hypertension, tenderness, again, at the surgical site, fatigue and lethargy due to increasing waste products in the blood, fluid retention, such as peripheral edema, or edema in their hands or around their eyes, because the body's volume is not being regulated, and the urine output is descending. It's not enough filtering by the kidney. Okay, so the BUN is going to go up, and the creatinine, the creatinine is also going to go up. Okay, the term azotemia, again, is just another term. We mentioned uremia before. Uremia just means I have an elevated urea in my blood, so uremia, and that's an indication that just means kidney failure. Azotemia is very, very similar. It's basically a buildup of BUN and creatinine in the blood, so that's why it's emia at the end, and it's an indication of kidney failure. Okay. So what can we do for acute rejection? Well, adjustment of the immunosuppressant drugs upwards, or changing of the immunosuppressant drugs in the hopes of stopping the acute rejection. Okay, and finally, chronic rejection, which happens over years, and it's typically just from gradual destruction of blood vessels and scarring of the blood vessels and the tissue. That's causing loss of nephrons in the kidney. So the kidneys are just gradually failing over years. Okay, and the symptoms of chronic renal failure begin to return. So the increased BUN and creatinine, the increased fluid retention, hypertension, hyperkalemia, fatigue, poor wound healing, bruising, bruising, all of those symptoms are returning. Okay. And the treatment for this is really to continue on with the immunosuppressants to the point where the kidney fails that they now require dialysis. Okay. Okay, so the next one is infection. So we're always thinking of infection because they're on immunosuppressants, and the kidneys also at risk for developing infection, right? And this is one of the more common causes of morbidity and mortality in the first year after transplantation is infection. Okay. So how do we know someone has an infection? Well, it's a bit harder when someone's on immunosuppressants because they don't typically behave the same way as a patient that's not on immunosuppressants. So they may have a low-grade fever, okay? But immunosuppressants can stop people from developing fever sometimes. So low-grade fevers, discomfort at the infectious site. So say the kidney's infected, say they have a pneumonia. We're always on the watch out for any potential signs for infection when someone's immunosuppressed. Okay, so someone might come in with abnormal vital signs, hypotension, tachycardia. So always keep infection in the back of your mind if someone is on immunosuppressants. Okay, we're very careful with hand hygiene, well, with any patient, but in particular in someone who is immunosuppressed. And monitoring for any signs of infection at the site, so the surgical site, for example, or systemic symptoms. So if someone comes in and they have a cough, they're a bit short of breath, well, we're going to get a chest x-ray looking for pneumonia. If someone comes in hypotensive and tachycardic, while on immunosuppressants, we're going to think of sepsis. So we're going to go looking for the source of a bacterial infection. Okay, and typically we'll take blood cultures as well. Okay, looking to see if we can grow bacteria in the blood. Okay, so we spoke about organ rejection, infection because of the immunosuppressants that patients are taking. What are some other complications? Well, you can have ischemia of the kidney itself. So maybe there was a bit of a delay from when the donor kidney was removed and put into the recipient. And now there's been enough ischemia or lack of blood supply to that kidney that once it's been in the recipient, it's showing signs of ischemia and injury. Okay. So, well, what can we do for that? Well, it's monitoring, right? Is this kidney going to survive? Let's monitor the urine output. Let's monitor the BUN and creatinine to see if the kidney is going to survive or fail because of ischemic damage during the removal process and the insertion into the patient. Okay. So again, really important to monitor that urine output of at least 30 mils per hour. That's a minimum. Okay. And if the kidney is failing, well, the patient is going to need to go on to dialysis. Sometimes the donor kidney can be biopsied to see if it's ischemic damage from the whole process of being removed from one patient and being inserted into the recipient, sorry, or is it organ rejection? Sometimes it's hard to know the difference, so a kidney biopsy can be obtained to see which one it is. Okay. So renal artery stenosis. So this just means, okay, where the new kidney was inserted, they had they had to sew up the artery to the patient's arteries to allow blood supply to go to the new kidney. Well, scarring can occur there. And if there's enough scarring, the artery will become narrowed. And that's going to lead to, sometimes we'll hear a bruit. So that turbulent flow of blood through the narrowing artery. We may see that the kidney function is worsening. So increased BUN, increased creatinine, decreased urine output. Remember, the donor kidney is really the only functioning kidney in the patient now. The two other kidneys that they had are non-functioning. So an elevated BUN and creatinine are going to be an indication that the new kidney is failing. Okay. Now, if this were a consideration, renal artery stenosis, well, sometimes they can, a surgical team can go in and balloon angioplasty, so stretch out the artery to open it up and get rid of that scarring. Okay. Sometimes, so the next one is thrombosis. Sometimes the artery that's feeding the kidney or the vein that's leaving the kidney to return blood to the venous system can become thrombosed, right? So a thrombosis of the renal artery or renal vein is going to definitely stop that kidney from functioning properly. So it's going to result in decreased urine output, volume overload, all the things you would think of when a kidney is failing. Okay, and typically, if that is the case, the kidney needs to be removed. Okay, so those are the main complications. So think of organ rejection, especially the first two, as the immune system is trying to attack the donor kidney. Chronic organ rejection is just the blood vessels are starting to scar up, the tissues of the kidney is starting to scar up, because really in the end it's still someone else's kidney, right? But I don't want you to think that a lot of patients that receive kidneys end up with chronic failure, because many patients go for years and years and years while they're taking their immunosuppressants with a proper functioning kidney transplant. Infection purely from those immunosuppressants. And ischemia, that's during the procedure, right? Removing the kidney and inserting it into the patient. Renal artery stenosis, that's because they had to sew up that artery and the vein to insert the new kidney. So it can become stenotic, which is narrowed, or the vein or the artery can completely clot up, leading to renal failure. And in terms of thrombosis, it needs to be removed. Okay, let's move on. Okay, so let's do the questions at the end of chapter 58 together. Number one, the nurse is assessing a client who has end-stage kidney disease. Okay, so end-stage chronic renal failure. Which of the following findings should the nurse expect? Anuria is the patient is not making urine, so that could definitely occur in end-stage renal failure. Okay, so often patients with chronic renal failure towards the end, they have oliguria, meaning decreased urine output, and then finally they're anuric. They don't make any urine at all. Marked azotemia. So azotemia is just a fancy word for elevated BUN and creatinine due to renal failure. Okay, so yes, crackles in the lung would be an indication of volume overload, and in end-stage renal failure, you often have fluid overload. So swollen legs, swollen hands, pulmonary edema with shortness of breath. Increased calcium level, no. Right, so the kidneys are responsible for converting inactive vitamin D to active vitamin D so that the gastrointestinal tract can absorb calcium. So because they're failing, they're not producing active vitamin D, which is going to reduce serum calcium. That's going to activate parathyroid hormone to start breaking down the bones to release calcium and maintain serum calcium. And at the same time, it's going to cause an elevated phosphorus level because calcium in bone is in the form of calcium phosphate. So phosphate levels are often elevated in renal failure. And so are magnesium levels because the kidneys can't get rid of magnesium. So in actual fact, we often give patients active vitamin D in the form of calcitriol because we know their kidneys can't convert the inactive form of vitamin D that comes from the skin. So we give them active vitamin D called calcitriol. Okay. Okay, so that's not the answer. So E, proteinuria. So as the kidneys are dying, the glomerulus, which is the filtering part of the kidney, is now allowing proteins to leak across, blood to leak across, and we may see red blood cells in the urine, and we'll start to see proteins in the urine because the kidney is slowly dying. So the answer is A, B, C, and E. 2, a nurse is planning post-operative care for a client following a kidney transplant. Which of the following actions should the nurse include? Obtain daily weights? Absolutely, right? Daily weights are going to allow us to assess volume status. So if someone gains 3 pounds in 24 hours, that's all going to be fluid. And because the kidneys are so involved in maintaining volume and fluid status in the body, it'll be a good indication of the functioning of the kidneys. So definitely obtaining daily weights. Assessing the drainage for the dressing for bloody drainage, definitely, right? Are they bleeding at the wound site? Do they have a hematoma, which is a blood collection at the wound that may need draining if it's large enough? Replace hourly urine output with IV fluids. Okay, that's a strange sentence to me. So it makes me think that I should calculate how much urine is being lost and then give it in the form of IV fluids. But really what we want to do is monitor urine output to make sure they have a good urine output, at least at a minimum 30 mils per hour. Usually we want to see even higher than that. And how are we going to maintain that urine output post-operatively? IV fluids, because they're likely not able to drink yet. Okay, so C is going to be an answer, just a kind of a weird way to phrase it. Expect oliguria in the first 4 hours. No, shouldn't expect oliguria. We want to see that the kidney is immediately filtering and making urine. Monitor blood electrolytes? Absolutely. Sodium, chloride, and most importantly, potassium. So the answer is going to be A, B, C, and E. Number 3, a nurse is teaching a client who is post-operative following a kidney transplant and is taking cyclosporin, immunosuppressant. Which of the following instructions should the nurse include? Decrease your intake of protein-rich foods. Post-operatively, not necessarily, because protein allow for proper wound healing, right? Your tissues are made up of a lot of protein. So making sure the patient's eating a good protein diet initially after surgery is a good idea for wound healing. Take this medication with grapefruit juice. Now, cyclosporin is another one to add to your list that you cannot take with grapefruit juice because it alters the levels of cyclosporin, right? So now we have benzodiazepines, calcium channel blockers, statin drugs for cholesterol. Cyclosporin is another one where you can't take grapefruit juice. Monitor for and report sore throat to your provider. Absolutely. That's an infectious symptom. So we want to report it because any infectious symptoms while on immunosuppressants are very important to report. So whether it's a sore throat or a cough or shortness of breath, they all need reporting, okay? The last one, expect your skin to turn yellow. No, your skin would turn yellow in liver failure. Yellow skin is typically jaundice, and that's from liver failure or cirrhosis, okay, not from kidney failure. So the answer there is C. Number 4, a client who is scheduled for kidney transplantation surgery is assessed by the nurse for risk factors of surgery. Which of the following findings increase the client's risk of surgery? Age over 70. Age over 70 would basically be a risk factor for almost any surgery, okay, including renal transplantation. BMI of 41, absolutely. Okay, that would be morbid obesity, and morbid obesity is a risk factor for any surgery because of the development of pneumonias, atelectasis, skin breakdown, deep vein thromboses, PE. Okay. Next one, administering NPH insulin each morning. So this is kind of a roundabout way of telling you that this patient's diabetic. So diabetes is a risk factor for surgical complications, right? So diabetics, we consider them to be immunosuppressed. So they're going to have poor wound healing with this surgery due to the fact that they have diabetes, okay? So I don't like the way it's worded. Why couldn't they just say a patient with diabetes? But anyways, past history of lymphoma. So anyone who has a past history of a cancer is going to be higher risk for surgical procedures. Okay, maybe they had chemotherapy years ago. So this just says past medical history of lymphoma. It doesn't say that they have active cancer. But lymphoma is a type of cancer, and it would increase your risk, increased risk of surgical complications. And on top of that, the fact that you're on immunosuppressants after the kidney transplantation could cause a reactivation of the lymphoma that the patient had years ago, because they're immunosuppressed for the rest of their lives. Okay? Blood pressure averaging 120 on 70. No, that's totally fine. Blood pressure, that's not a risk factor for kidney transplantation. Okay, so the answer is A, B, C, and D. 5, a nurse is teaching a client who is scheduled for kidney transplant about organ rejection. Okay. Which of the following statements should the nurse include? A, expect an immediate removal of the donor kidney for a hyperacute rejection. Yes. So a hyperacute rejection is where immediately the immune system is shutting down the kidney and destroying the blood vessels. B, you might need to begin dialysis to monitor your kidney function for a hyperacute rejection. Okay, this is a bit of a strange sentence to me. So you might need to begin dialysis to monitor your kidney function for a hyperacute rejection. But that's not why someone would get dialysis after a kidney transplant. So you would get dialysis after a kidney transplant if the donor kidney was failing and your blood is filling up with toxins, maybe high potassium, volume overloaded. So that's the reason why you're getting dialysis. It's not to monitor for hyperacute rejection. Okay, so that's a strange one, but that's not correct. C, a fever is a manifestation of acute rejection. Yes, acute rejection is inflammation, and inflammation releases interleukins, prostaglandins, and they go to the hypothalamus and create a fever. Okay. And what else? D, fluid retention is a manifestation of an acute rejection. Absolutely. The inability of the kidney to regulate volume of fluid is going to cause fluid retention. E, your provider will increase your immunosuppressant medications for a chronic rejection. No, it's not going to help, right? It's actually just going to put them at higher risk for infections by increasing the immunosuppressants. But chronic rejection is just gradual destruction of the kidney leading to tissue fibrosis and loss of neurons. So that won't help. So the answer is A, C, and D. Okay, so in this part of the module, we're going to talk about acute kidney injury. So something that has acutely injured the kidney, leading them not to function properly. And when the kidney doesn't function properly, just think of all the things that occur. Your BUN and creatinine go up, your potassium can go up, you can develop volume overload, peripheral edema, you can develop a metabolic acidosis. So all of this could occur acutely if you had something that suddenly injured the kidneys. Compared to chronic kidney disease, which is a gradual process of descending function of the kidneys. I mentioned before, typically from diabetes or hypertension, but there's a whole host of diseases that affect the kidney and can lead to chronic kidney disease over years. Okay, and we'll talk about a condition of the kidney called polycystic kidney disease. Okay, so let's just do an overview of genitourinary tract disorders. So when we're talking about UTIs, we can be referring to cystitis, which is a bacterial infection of the bladder, and pyelonephritis, which is a bacterial infection, usually, of the kidney. Okay, and both of these are typically treated with antibiotics. Most of the time in cystitis, patients go home with an oral antibiotic for anywhere from 1 day to 7 days, and it usually quickly clears. Okay, we typically encourage increased fluid intake to get the antibiotics into the bladder. Pyelonephritis is a more serious condition. It's an infection of a kidney, which can result in systemic symptoms such as fever, fatigue, weakness. They often have flank pain. And on top of that, they have all the symptoms of cystitis because the bacteria started in the bladder and then ascended up the ureter into the kidney, leading to pyelonephritis. So, depending on how sick they are, will determine whether they need to come into hospital for IV antibiotics or whether they can go home on an oral course of antibiotics. Below that, glomerulonephritis is an inflammatory condition, typically, of the glomeruli. And because the glomeruli become inflamed, they become leaky, and they cause blood and some protein to leak into the urine. Okay, they can also have flank discomfort because the kidney is, or the kidneys, typically it's both of them in glomerulonephritis, since it's usually a systemic disease. There's typically another disease that the patient has, which is resulting in glomerulonephritis. Okay, so they can have flank pain, they can have low-grade fevers, they can be systemically unwell, and we're picking up blood and protein in the urine. A classic disease causing glomerulonephritis would be strep A pharyngitis, which causes an immune response, and the antibodies attack the glomeruli, resulting in glomerulonephritis. Okay, and if you have severe glomerulonephritis that's not responsive to treatment, then you can end up with acute kidney injury first, and then chronic kidney injury if it persists, and finally end-stage kidney disease. Okay, so think of glomerulonephritis as an inflammatory condition. Nephrotic syndrome is best thought of as a condition of the glomerulus that causes them to be very leaky of protein. So you get a lot of albumin leaking into the urine, so you have proteinuria, and because of that, you have decreased albumin in the bloodstream. And I'll explain on another slide why you typically have increased fat in the bloodstream as well with nephrotic syndrome. So if you have a lot of protein leaking into your urine and your albumin's low in your bloodstream, the hallmark of nephrotic syndrome is going to be edema, right? They're going to be edematous in their legs, around their eyes, in their hands, on top of having the hyperlipidemia that goes along with it. Okay. Acute kidney injury is just what it says. The kidney has been acutely injured by some kind of recent event. So it could be anything. It could be a glomerulonephritis. It could be nephrotic syndrome. It could be from severe dehydration. Remember the different categories of acute kidney injury: pre-renal, intrarenal, and post-renal. Okay? So for example, glomerulonephritis is going to be an intrarenal injury to the kidney because it's a direct attack on the kidney. Nephrotic syndrome is going to be intrarenal. Dehydration or anything that causes hypotension is going to be pre-renal. BPH, or inability to empty your bladder properly, can lead to post-renal acute kidney injury. Okay, so below that is chronic kidney disease. And chronic kidney disease can occur from an assortment of repeated injuries to the kidneys. So for example, someone who has recurrent pyelonephritis, so a bacterial infection to the kidneys, can be left with chronic kidney disease. A patient with severe glomerulonephritis, an antibody attack on the kidneys, can be left with chronic kidney disease. Diabetes, which presents as a nephrotic syndrome, they get leaky glomeruli, well, that can result in chronic kidney disease. Okay? The most common causes of chronic kidney disease are hypertension, so chronic hypertension for years, and diabetes. Okay? So diabetes is, chronic kidney disease is really the end of the result of an assortment of different diseases that are causing the kidney to lose its filtering ability. Okay? And finally, end-stage kidney disease is really where the kidneys have lost so much of their filtering ability that now the patient is facing hemodialysis or peritoneal dialysis to clear the waste, to maintain volume regulation, to maintain normal electrolytes in the blood, all the aspects that occur with end-stage kidney disease. Okay, so remember, acute kidney injury is something that's happened rather suddenly. Okay, it's not someone who's gone on with gradually weakening kidneys over years, which we'll call chronic kidney disease. So we're going to break up acute kidney injury into pre-renal, renal, and post-renal as causes, right? So remember what pre-renal is. Anything that reduces blood supply to the kidneys will cause the kidneys to go into a bit of shock and lead to acute kidney injury because they're not getting enough blood supply. Okay? So examples of pre-renal acute kidney injury. Well, how about someone who's hypotensive? So why would you be hypotensive? Maybe you have profound diarrhea. Maybe you have a gastrointestinal bleed that's causing you to be hypotensive. Maybe you had cardiac arrest, or you had a massive heart attack with congestive heart failure, right? Anything that reduces blood supply to the kidneys resulting in acute kidney injury is called pre-renal renal failure. Intrarenal failure, or renally caused renal failure, can be from a direct trauma to the kidney. So say someone got hit forcefully on the back, that could injure a kidney. Certain drugs directly harm the kidneys. I mentioned vancomycin and aminoglycosides as two common ones that we need to monitor because they harm the kidneys. And there's many autoimmune type diseases that can also injure the kidneys, such as lupus, all kinds of glomerulonephritis. So for example, post-streptococcal glomerulonephritis would be an intrarenal acute kidney injury. Okay? So anything that directly hits the kidney with a disease and causes acute kidney injury, that's a renal cause. Post-renal cause is blockage of the system after the kidney, right? Post-renal. So a kidney stone that's blocking the ureter. A patient with benign prostatic hypertrophy that's unable to urinate because their prostate's so enlarged. And they always have urine filling their bladder, and they have back pressure to the kidneys, causing them to fail. Okay, that would be post-renal. A patient with a spinal cord injury where they can't sense that their bladder is full, and they have back pressure of urine and increased pressure to the kidneys, putting a stress on the kidneys. That would be post-renal issues. So if we look at the slide on the left here, let's just answer them as we go along. Recent infection of the kidney. That's going to be a renal issue causing AKI. Certain medications, that's a renal issue causing AKI. Severe dehydration, that is a pre-renal issue causing hypotension. Exposure to heavy metals or toxic solvents, that is a direct hit on the kidney. That's a renal issue. Blood loss and shock, that's a pre-renal issue. So whatever the condition you're looking at, just think of it, is it something that happened before the kidneys, something that directly hit the kidneys, or something that's after the kidneys? Okay? So what findings do we expect in acute kidney injury? Well, when someone has acute kidney injury, the kidneys are not working temporarily, right? They usually recover. Not always, but most of the time they recover, and we'll discuss that. But if the kidneys aren't working, they're not going to fulfill all of the functions that they're supposed to do. So the first one, fluid overload. Okay, so how does someone present with fluid overload because their kidneys have acutely failed? Well, peripheral edema, shortness of breath because there's fluid now building up in the lungs, right? They may have hypertension because of the fluid overload. The dysrhythmia is increasing levels of potassium that are now irritating the heart, leading to cardiac arrhythmias. The dyspnea, that's just from the fluid overload. Okay. What else can happen? So as the toxins are building up in your bloodstream, the brain can be affected. Lethargy, fatigue, confusion, seizures. Okay. The electrolyte imbalance that you should always think of with kidney failure, whether it's acute or chronic, is hyperkalemia. That is the deadly one. Okay. All right. Let's move on here. So in terms of the phases, so let's just look at the phases a bit. So the onset of acute kidney injury is from the injury, whatever it is, right? So if it was from severe diarrhea and vomiting resulting in hypotension, that's the onset. That is the injury, right? And it's going to result in oliguria in the kidneys because the kidneys are saying, well, I'm not getting blood supply, so I'm going to stop making urine so I can reabsorb all this fluid to try and stop myself from becoming fluid depleted. So just depends on the injury. And then there's an oligoureic phase where the kidneys start to shut down from the injury. Okay, so if we gave someone too much vancomycin and we injured the kidneys will not be able to produce proper amounts of urine, and we define that as less than 400 milliliters per day or 30 mils per hour. And this phase can last for weeks, right? So the kidneys in this phase have taken a direct hit, whether it's pre-renal, renal, or post-renal. And as they recover, typically they recover because we're treating the underlying problem. So if it's hypotension, we're giving IV fluids. If it's an intrinsic renal injury, well, we're removing the offending agent, such as the vancomycin or the aminoglycoside. And the kidneys start to recover, and they have this diuresis phase where there's an increased urine output. They diurese, the nephrons are waking up and they're starting to produce tremendous amounts of urine. Okay, and this can last a couple of weeks. A perfect example is someone who's been chronically obstructed with BPH, and the kidneys have grown accustomed to it, and then suddenly we put a urinary catheter in, and the kidneys start to wake up. So they were oligouric, and now we've relieved all that pressure that was in the bladder, and the kidneys start to wake up, and they have this diuretic phase where they urinate tremendous amounts of urine because we've solved the underlying issue that was causing the acute kidney injury. So the kidneys are really able to recover in acute kidney injury. Okay, and then there's the final recovery phase where the kidney returns to normal, the BUN and creatinine return to normal, and this can take months up to a year. Okay, but remember, acute kidney injury is usually survivable because by treating the underlying problem, the kidneys have the ability to recover. Okay, so still talking about acute kidney injury, let's look at the labs. So if the kidneys are injured, well, we're going to see an increase in creatinine, and we're going to see an increase in blood urea nitrogen, okay, pretty quickly. Changes in specific gravity just depend on what the underlying injury is. So if the underlying injury is dehydration, well, the kidneys are going to do everything they can to reabsorb fluid to help with the dehydration. So you're going to have a high specific gravity, right? So it kind of just depends on what the underlying issue is. Okay, if it's an intrarenal problem, okay, where the kidneys have been directly injured, say by a drug, such as an aminoglycoside, well, they've lost the ability to concentrate urine because they're injured. And concentrating urine takes kidney function, right? So so they may have dilute urine because the kidneys have been directly injured. So specific gravity just depends on the condition. Electrolytes, what's the one you need to remember? Hyperkalemia, right? And sure, you can have an elevated phosphate as well and a decreased calcium. Why does that happen? Because the kidneys are temporarily not working. Vitamin D isn't being activated, so serum calcium is going to be low since there's less absorption from the gastrointestinal tract. And why is phosphate high? Because parathyroid hormone is now breaking down calcium and phosphate from the bones to maintain serum calcium. Okay. Why is hematocrit potentially a bit low? Well, likely because erythropoietin isn't being secreted as much, so the bone marrow isn't making as much red blood cells. Urinalysis, it just depends on what the underlying cause is. Okay, so if it's pyelonephritis causing an acute kidney injury, well, we expect to see a positive leukocyte esterase, positive nitrates, positive white blood cells. So it kind of just depends on what the problem is. Okay, if it happens to be pyelonephritis, glomerulonephritis, which is an inflammatory condition of the kidneys, say in lupus, sometimes they'll produce what are called casts, right? They'll produce casts in their urine, and and what are casts? Casts are basically just blood and white blood cells that have gotten stuck in nephrons because the glomerulus was injured, and then they got released and put into the urine. So whenever you see casts, it's an indication that the kidneys are being injured. Otherwise, you wouldn't see the casts that were formed in the nephrons. Okay? And lastly, metabolic acidosis can occur because the kidneys aren't functioning properly. So what kind of diagnostic tests can we do? An X-ray of the abdomen is close to useless. We get an outline of the kidney, but that's about it. We don't see very much on an X-ray of the abdomen looking at the kidneys. Ultrasound can be really useful. It shows us the kidneys, it shows us the size of the kidneys. We can see if there's fluid backup to the kidneys called hydronephrosis. We can see if there's masses on the kidneys. We can look at the bladder to see if the bladder is not emptying properly. So very, very useful. CAT scan or MRI, very useful. Again, it'll show us the kidneys, the ureters, and the bladder. Okay, so let's look at some interventions first, and then we'll go on and talk about the treatment of AKI. So monitoring vital signs. So if someone is profoundly dehydrated from vomiting and diarrhea, they're going to be hypotensive. That could be the cause of their pre-renal AKI. If they have a GI bleed, we need to monitor. Well, we've discovered the cause of the AKI, and we need to monitor their vital signs, right? They may be hypotensive as well. So it just depends on the underlying condition. And really, that's what we need to find, right? Is it a pre-renal? Is it something that we're giving them, such as a drug that's harming the kidneys? Or is it a post-renal issue where they're blocked, say, from BPH or a spinal cord injury or a kidney stone? Okay, so monitoring vital signs, very important. Monitoring lab values. So what's their BUN doing? What's their creatinine doing? What's their potassium doing, right? We want to know if they're continually going up in the bloodstream, which indicates furthering or worsening of the acute kidney injury. Monitoring urine output is going to tell us the function of the kidney. And if it falls below 30 mils per hour, okay, that's an indication that the kidneys are in big trouble. Avoiding any nephrotoxic drugs, right? That is going to be a direct hit on the kidneys, an intrarenal injury. Assessing volume status so that patients don't go into pulmonary edema, right? Pulmonary edema is from fluid overload, typically from heart failure. Okay. What about their diet during acute kidney injury? Well, they can't drink unrestricted fluid intake because they're going to become fluid overloaded. So they may very well be on a restricted fluid intake. And also restriction of potassium rich foods because their kidneys aren't working. Phosphate's going to be elevated in their blood, so reducing phosphate in the diet. Reducing salt, so sodium in the diet, because salt makes you drink, and that increases volume. And they're typically hypermagnesiemic, so lowering magnesium in the diet. And that's why we do not give magnesium-based antacids to patients with renal failure. Monitoring the EKG if there's a concern about electrolyte abnormalities, in particular potassium. I know I'm repeating that potassium, but it's important. So if we see an elevated potassium, we're going to do an EKG, looking for peaked T waves. A widening QRS is concerning in the setting of hyperkalemia. And arrhythmias. So patients with hyperkalemia, sure, they can get a peaked T wave, they can get a widening QRS, and as the QRS widens, they get into trouble with rhythms such as ventricular tachycardia, which is dangerous. Monitoring daily weights, very important. Again, because daily weights are an indication of your volume status. Okay, and now we'll go on and talk about some medications for acute kidney injury. Okay, so acute kidney injury, it just depends on the cause and what we're going to do. But IV fluids may be required if someone is profoundly dehydrated and showing signs of acute kidney injury, or someone with melena or vomiting blood. They're going to have reduced perfusion to the kidneys. They're going to need IV fluids and possibly blood products as well, right? So IV fluids in the setting of a pre-renal issue or even a renal injury can help the kidneys start to produce urine again, because they're in a shock state when they had the injury. Okay, so we want to give IV fluids to increase kidney perfusion. Now, we also use IV fluids after we've corrected the problem, such as BPH, where we've put a Foley catheter in and they're in a diuresis stage. And they're producing tremendous amounts of urine abnormally, but the nephrons are waking up and they're making all this urine, and we need to replace all that loss of urine with IV fluids. Okay, so I think of the kidneys as flowers. If they're not perfused properly with blood, so a pre-renal injury, they start to wilt. And as soon as we give them IV fluids, they start to wake up again and work properly. Sometimes we need to encourage them even more so than just IV fluids, and we can give them diuretics. Okay, so whether it's furosemide, which is a loop diuretic, mannitol, which is an osmotic diuretic, which we usually use for head injuries due to intracerebral edema, we can use them to promote the kidney to start working again. Okay, there's another loop diuretic that's listed called ethacrynic acid. It's a powerful loop diuretic that can also force the kidneys to start making urine. And really, that's what we want to do with diuretics. Okay. What about, so there's a drug called polystyrene that we sometimes use, so sodium polystyrene, sorry, and it's a medication that we give orally, and it binds potassium in the gastrointestinal tract. We don't use it very much anymore, okay? So you can know about it. So sodium polystyrene, it's called Kayexalate, and it binds, so it pulls potassium out of the serum into the gastrointestinal tract and lowers serum potassium. Just so you know, you won't see it used very much anymore because it can really harm the gastrointestinal tract and cause ischemia in the gastrointestinal tract, so we're using it less and less. But if you see it as a treatment for high potassium, then select it. I mean, it's still a treatment for high potassium, but we're using it less and less due to the risks. Okay. What else can we use? We can use sodium bicarbonate if someone has metabolic acidosis. Usually what we do is just give them IV fluids and flush out the acids through the kidneys as the kidneys start to wake up again by the IV fluids. But if we had to, we could give them sodium bicarbonate to try and raise the pH and to try and correct the metabolic acidosis. If someone had a really elevated potassium and we wanted to get it down fast, well, we give a couple of things. So let's just talk about this a bit because it's important. We give insulin. Okay, so why are we giving insulin? IV insulin to someone who has acute kidney injury or chronic injury and they have high potassium. Well, insulin forces glucose into cells, but while it's doing that, it's pulling potassium with it. So it's hiding the serum potassium into cells, and that lowers serum potassium. That's good. That's what we want to do, to hide the potassium within the cells temporarily. Why do we give the dextrose? Because we're giving insulin. And if we give insulin, we're going to drop serum sugar. So we have to give a dextrose drip because we're giving insulin. Calcium. So what does calcium do? So we give IV calcium gluconate because calcium gluconate is very protective to the heart in the setting of high potassium. It's almost like a shield. So one of the first drugs we give when we see hyperkalemia is calcium gluconate IV. Okay. And another medication that you may come across being used to lower serum potassium is albuterol. Albuterol is a beta-2 agonist, and it stimulates, well, it opens up the bronchial tubes for asthma or COPD, but it also stimulates cells to take in potassium, so it lowers serum potassium. That's why we use it, right? And the last drug we use for moving potassium into cells is bicarbonate, so HCO3, sodium bicarbonate. So why do we use that? Well, sodium bicarbonate, when we give it to a patient with high potassium, what's it going to do? Well, we're making the blood alkaline with sodium bicarbonate. That's going to cause cells to give up their hydrogen ions to buffer the sodium bicarbonate that's in the serum. And when you take hydrogen ions out of cells, there's a pump that takes potassium out of the serum and puts it into cells. So by giving IV sodium bicarbonate, we're actually moving potassium into cells. Okay, so let's just say someone comes in hyperkalemic. What can we do? So dextrose and insulin, great. Albuterol nebulizer, great. Calcium gluconate IV to protect the heart, not to lower the potassium, but to protect the heart. And lastly, an amp or 2 amps of sodium bicarbonate to shift hydrogen ions out of the cells and potassium ions into the cells, lowering serum potassium. Okay? And we also have some phosphate binding drugs if we find that the phosphate is very elevated in the bloodstream. But I would say the potassium and the treatment of hyperkalemia is really important. Okay, so understand why we use insulin, albuterol, sodium bicarbonate, and calcium gluconate. Okay, so let's talk about chronic kidney disease, which is typically a progressive, irreversible kidney disease, which is really unlike acute kidney injury, which is highly reversible if we treat the underlying issue, such as hypotension, and give IV fluids. Chronic kidney disease is really a destruction and loss of nephrons. And end-stage kidney disease, which is approaching the need for some form of dialysis or renal transplantation, is when you have about 90% of your nephrons destroyed or lost. And we define the stages of kidney disease based on the GFR. Okay, so stage 1 kidney disease has a very good GFR, greater than 90 milliliters per minute. Okay, So that would indicate really minimal kidney injury, and the GFR is basically within normal limits still, and it just progresses downwards, okay, until you reach stage 5, where you have a GFR of about 50 milliliters per minute, 15 milliliters per minute. Sorry. Typically at stage 4, where the GFR is 30 or under, we're really looking hard at medications, because there's many medications that we have to alter the doses when the GFR falls below 30. Okay. So I won't go through all the stages here. Just know that they're based on the glomerular filtration rate. Now, when the kidneys get to the point where they're either unable to control volume status in the body, so patients are getting pulmonary edema, peripheral edema, congestive heart failure, okay, they may need to move on to dialysis or renal transplantation, okay, because we can't reverse chronic kidney disease. So that's one indication for dialysis, volume overload. Another one would be hyperkalemia, right? Another one would be excessive waste products. BUN and creatinine are indicators of excessive waste products, and that would be another reason for dialysis or transplantation. Resistant metabolic acidosis, because the kidneys are so important in controlling acid-base functions in the body, would be another reason for dialysis or transplantation. Okay. How can we prevent the progression of a patient to end-stage chronic kidney disease? Well, there's definitely some ways that we can all prevent that. So making sure that we're drinking proper amounts of fluid that keeps the kidneys nicely hydrated. Reducing cigarettes, so stopping smoking, because they're really hard on the kidneys. And they cause hypoxic damage to the kidneys. And the chemicals that are in cigarettes are directly harmful to the kidneys. And they're the #1 cause of kidney cancer and bladder cancer. Limiting alcohol, because again, alcohol, not only is it hard on the liver, but it's hard on the kidneys. And by the way, when you develop liver failure, often that turns into renal failure, called hepatorenal syndrome. Managing chronic conditions, in particular diabetes and hypertension. Those are the #2 causes of chronic kidney disease. Okay. Someone who's diabetic often has albumin checked in their urine at least 2 or 3 times a year. Why do we do that? Because when we start to pick up microalbuminuria in a diabetic, it's an indication that the glomeruli are starting to become leaky and spilling albumin into the urine. Okay? And definitely limiting NSAIDs. NSAIDs in anyone with a renal issue is really not a good idea, because NSAIDs are hard on the kidneys. By inhibiting prostaglandins in the kidneys, they reduce GFR, and they're harmful to the nephrons. The kidneys are very reliant on prostaglandins, and NSAIDs inhibit prostaglandins in the kidney and the gastrointestinal tract. They lead to ulcers and gastritis in the GI tract, and renal injury and chronic renal failure in the kidneys. So let's look at some common risk factors that lead to chronic kidney disease. Well, if you have acute kidney injury over and over again, because every time you have an acute kidney injury, you do injure the kidney a bit. So if you have recurrent bouts of acute kidney injury, such as from recurrent pyelonephritis, which is bacterial infection of the kidneys, it's going to result in chronic kidney injury. Okay. What else? Diabetes mellitus, for sure. Type 1 or type 2. Glomerulonephritis. There's many types of glomerulonephritis, but if you develop glomerulonephritis, that's a direct injury to the kidney, and that puts you at risk for chronic kidney disease. Recurrent use of nephrotoxic drugs, whether they're antibiotics such as aminoglycosides, which is gentamicin, or NSAIDs, or any chemicals that harm the kidneys, medications or drugs, right? I gave an example of smoking is harmful to the kidneys. Hypertension, so chronic high blood pressure on the glomeruli causes them to be injured. So controlling high blood pressure is really important. Okay. Autoimmune disorders, just only because autoimmune disorders typically cause, or many of them can cause glomerulonephritis, such as lupus. Polycystic kidney disease we'll talk about. It's an inherited disease where you get massive cysts forming all over the kidneys on both sides, and that can lead to chronic renal failure. I think I should say pyelonephritis in your book, by the way, but chronic pyelonephritis is where you get recurrent kidney infections, and often this can occur in children into adulthood, and they've had so many of them that the kidneys have become scarred and they're not as strong anymore, and they develop chronic kidney disease. Okay, so those would be the main ones. So the expected findings in chronic kidney disease, well, just go back and look at the expected findings of someone that is about to get a renal transplantation, right? It's going to be the same. So all these symptoms in so many organs, because the kidneys, when they start to fail, give symptoms to many organs. So just go back and listen or look at the expected findings of someone who just prior to getting a renal transplant, it'll be the same as the symptoms here. Okay, so diagnostic tests in chronic kidney disease. This is going to be a repetition. So what are we going to see in the urine? Well, the glomeruli are weakening and you have less of them. Typically in end-stage kidney disease, you have 90% less. So the remaining nephrons are working overtime, and they're going to start to leak blood, protein, into the urine. And the specific gravity is going to be lower. Why? Well, if your kidneys are weak and they're failing, they're unable to concentrate the urine so that they can reabsorb water into your bloodstream, right? They're losing their concentrating ability, which takes strength by the kidneys, right? So protein, blood, and reduced specific gravity. Your creatinine in your bloodstream, elevated because it's not being filtered properly, right? BUN, elevated. You're still breaking down proteins and amino acids, and the amino acids need to be cleared. They get converted to urea in the urea cycle in the liver, but they need to be cleared by the kidney. And if the kidney's not functioning, your BUN goes up. Okay. Blood electrolytes. It's all about potassium. Increased potassium. That's what we care about, right? But sure, you're not clearing phosphorus from your bones. You're not clearing magnesium from your diet. So you can just imagine the diet of chronic kidney disease. Okay, low potassium, low phosphorus, low magnesium. Okay. CBC, we've mentioned that before. You're going to be anemic with chronic kidney disease because of the lack of erythropoietin. In fact, many patients that have chronic kidney disease require injections of synthetic erythropoietin to maintain their hemoglobin levels. Okay. So, in terms of the procedures, the imaging procedures, again, they're going to be similar to acute kidney injury. The ultrasound is just going to show us the size of the kidneys, and in chronic kidney disease, they often start to shrivel and get smaller, which is an indication that the kidneys are really not functioning properly. We may see a whole bunch of cysts on the kidney that could indicate polycystic kidney disease. So we use ultrasound, CT, MRI, just like we do in acute kidney injuries. A KUB is just another is an X-ray. So kidney, urine, bladder. Kidney, ureter, bladder is just an X-ray of the abdomen. Not very useful in chronic kidney disease. Okay. There's a whole bunch of other tests we can use to diagnose chronic kidney disease. Kidney biopsies to see what's actually causing the kidneys to fail. So a lot of it just depends on what do we think is going on. If it's clearly secondary to diabetes and hypertension, then a lot of these tests aren't going to be done. Okay, so they may not need a cystoscopy or a kidney biopsy and things like that. So it just depends on what we think is happening that's resulting in the chronic kidney disease. Okay, so let's just look at the typical renal diet. So, someone who has chronic kidney disease, I mentioned before, so ongoing chronic kidney disease, we may need to restrict their fluid intake because the kidneys just can't filter enough to control fluid volume in the bloodstream. So fluid restriction can definitely occur with severe chronic renal disease. Okay? Limiting those electrolytes that can build up in the bloodstream, so potassium, phosphorus, and magnesium can build up to dangerous levels, especially potassium. Sodium, again, should be limited because it makes you drink, and that increases vascular volume in the kidneys, may not be able to cope with the increased drinking. Okay. In general, you have a decreased protein diet in kidney. Remember, protein gets converted to amino acids, which gets converted to urea. So we want to have a low protein diet. Okay? Unless they're undergoing some kind of surgery or procedure or transplantation where you want wound healing to be promoted with an increased protein diet temporarily. Okay? Now, if someone is on dialysis, the hemodialysis or peritoneal dialysis, you can actually lose protein. So then it's fine, okay, to have a higher protein diet. But in general, someone who has chronic kidney disease and is functioning with their own kidneys still has a low protein diet. Carbohydrates tend to be higher, okay, they're processed just fine, and a moderate fat intake. So really, the carbs and the fats are okay. It's the proteins that you reduce in chronic renal disease. Don't forget about skin care. Like, patients with chronic renal disease have really poor wound healing, okay, because of all the circulating toxins. So wounds take a very long time to heal, and they're very prone to infection because when you have chronic kidney disease, you're also considered immunosuppressed. Okay, you just don't heal well, and you bruise easily because of all the circulating toxins. So really a lot of attention to skin care, making sure that there isn't any skin breakdown if they're in hospital, because the healing time is so long in these patients with chronic kidney disease. Administration of medications. So we always check a medication, especially if they have end-stage kidney disease and their GFR is under 30 milliliters per minute. Not their urine output, but their glomerular filtration rate. We have to adjust the doses of medications. So, for example, if a patient with normal kidneys takes an antibiotic 3 times a day, often in kidney disease, a patient may need to just take it once a day because the antibiotic isn't filtered very much anymore. Okay, there's certain drugs that are absolutely avoided in patients with chronic kidney disease. So I mentioned aminoglycosides and vancomycin we're super careful with. because they directly harm the kidneys. Amphotericin is an antifungal, and we're careful with giving that because it directly harms the kidneys. NSAIDs, we just avoid them because it's going to worsen the kidney disease for sure. ACE inhibitors. ACE inhibitors can cause hyperkalemia in patients with renal failure. So it can magnify hyperkalemia. So how does that happen? Well, remember, ACE inhibitors work by blocking the renin-angiotensin-aldosterone system. So when they block aldosterone, okay, they cause potassium not to be secreted into the kidneys. Well, patients with kidney disease already have a problem with their serum potassium, or they could anyways. And now we're giving them a drug that also elevates serum potassium. ACE inhibitors, okay, it's a bad idea. Spironolactone, another drug that elevates serum potassium, we would avoid in someone with severe chronic kidney disease. IV contrast dye for imaging tests such as CAT scans can also directly harm the kidney, so that would be an intrarenal kidney injury. So we're very careful with those as well. If we have to use contrast dye, we make sure the patient is really well hydrated so the kidneys have a good urine output and they can get rid of the contrast dye. Okay. Okay, let's look at some medications. I find this is a bit of an odd list in the book because anyways, it'll make sense when I talk about them. So digoxin is a drug that we use to control the rate of atrial fibrillation because it slows down the heart rate. So someone who comes in with rapid atrial fibrillation, we may use digoxin to control their heart rate. It's also been used for years, although not as much anymore, to increase contractility of the heart. Okay, so a patient in heart failure may be on digoxin. Digoxin is excreted by the kidneys. Okay, so we have to be careful with digoxin because patients can become dig-toxic because of the poor excretion by the weak kidneys. So we typically use lower doses of digoxin in someone with renal failure, and we're going to do dig levels, so dig serum blood levels, and we're going to monitor for symptoms of dig toxicity. And what are the first symptoms of dig toxicity? Malaise, so nausea, vomiting, loss of appetite, and then as it progresses, some visual changes can occur. Okay. Digoxin and potassium don't get along. So a low potassium caused digoxin to be much more powerful. So we monitor potassium levels if someone is on digoxin, especially if they're on a diuretic that can drain their potassium. Okay. Digoxin can be dialyzed off, so if someone's on dialysis, they're going to take their digoxin after dialysis, right? Otherwise, the dialysis will just remove the digoxin. Sodium polystyrene we spoke about. It's an oral medication that binds potassium. And since there's sodium attached to sodium polystyrene, sodium gets absorbed. And remember, try not to drink or consume too much sodium because it makes you thirsty and drink more, right? And it can lead to hypertension. So just mention. I also mentioned that we don't use very much sodium polystyrene to reduce serum potassium because it can be very harmful to the gastrointestinal tract. But just know that that's what we use it for, or is used for. Erythropoietin, or EPO, is injected, and it's a protein that stimulates red blood cell production in the setting of chronic kidney disease. So we really don't use it for anything else but chronic kidney disease, because in other anemias, it's not usually erythropoietin that's deficient. It's only deficient when in the setting of chronic kidney disease, because that's where it's produced. Okay. Ferrous sulfate we sometimes have to give because we're trying to maintain their hemoglobin levels and they're anemic. Okay. Calcium carbonate. So calcium binds to phosphate. So if someone has a very high phosphate in chronic renal disease, and I mentioned the phosphate comes from the bone breakdown to try and release calcium into the bloodstream, and parathyroid hormone does that, so it results in a high phosphate level. Well, we can use phosphate binding medications, okay? And calcium carbonate happens to be a phosphate binder because calcium binds with phosphate in the bloodstream, okay? So, what else? So furosemide. Or the other one I think you should also remember is butanamide. They're both loop diuretics. They both work the same way, but they're tough on the kidneys. Furosemide is nephrotoxic and it's ototoxic. So it's hard on the ears, hard on the kidneys. Okay. So sometimes we do have to use them in the setting of chronic kidney disease. But we're also aware that furosemide or bumetanide are nephrotoxic and can harm the kidneys, okay? But someone who's volume overloaded from chronic renal disease, sometimes we just have to give them a diuretic such as furosemide to drain the fluid, to try and force the kidneys to work and drain and have them make urine, okay? Sometimes we'll use thiazide diuretics to try and produce more urine. Potassium-sparing diuretics, we don't use very much. Again, I mentioned that in chronic renal failure because of the risk of causing hyperkalemia. Okay. Okay, so let's look at polycystic kidney disease, which is basically very, very enlarged kidneys, both of them, with numerous cysts, usually hundreds of cysts, that are causing the kidneys to become non-functional, okay? So this is a genetically inherited condition, and usually it happens in Caucasians, and most of the time it's autosomal dominant inheritance. So typically someone else in the family has this. Whenever a condition has autosomal dominant inheritance, someone else in the family is going to have it, because it means you just need to get one allele to have the disease, okay? So what are the expected findings in this? Well, typically there's an expected finding of family history of polycystic kidney disease. Patients come in with abdominal or flank pain because of the increasing size of these kidneys. And this is occurring over years, by the way. They can have really acute pain if one of these cysts were to rupture. So rupture of a cyst is very painful. So they could have a dull pain usually, but if a cyst ruptures, it's very painful. And they start to develop symptoms of renal failure, right? Hypertension, fluid overload. They can develop shortness of breath, all the symptoms of chronic renal failure. They may spill a bit of blood into their urine because these cysts are often filled with blood. And as the disease progresses, it often results in end-stage renal disease. Okay. So in terms of diagnostics, well, laboratory tests, we might see some blood in the urine. We're going to see protein leaking into the urine because the nephrons are cystic and absent. So the ones that are remaining are leaking blood, protein into the urine. And we're definitely going to see an increasing BUN and creatinine in the bloodstream. and a decreased creatinine clearance. So creatinine clearance is telling us what's the GFR of the kidneys, how powerful are these kidneys. And as your GFR or your creatinine clearance goes down, it's telling us your kidneys are getting weaker and weaker and weaker. Okay. In terms of diagnostics to look at the kidneys, ultrasound is fantastic. We can see all the cysts. We can measure the kidneys. So I would say ultrasound is typically the most useful test. But other ones are fine too. So a CAT scan or an MRI can also be used. Okay, so polycystic kidney disease intervention. So some of it's going to relate to the management of chronic renal failure, right? So let's look at the first one. So hypertension, well, it's because their kidneys are failing and they can't regulate their blood pressure anymore, right? So a lot of these patients will need medications to lower their blood pressure. And the main reason for this is, well, not only is high blood pressure a risk factor for heart disease, peripheral artery disease, strokes, but also it's really hard on the kidneys and it accelerates the loss of kidney function. So they'll develop renal failure even faster. Okay. Pain management. So the kidneys are enlarging, they have cysts on them. So often they need medications for the pain. Okay. We don't use NSAIDs in renal issues or renal disease because of the risk of injuring the kidneys further. Okay. Preventing infections. So they already have all these cysts all over the place, and the cysts are a perfect place for bacteria to grow. So prevention of pyelonephritis is important. So if someone were to develop symptoms of pyelonephritis, which is basically an infected kidney with bacteria, well, they're going to need antibiotics pretty quickly. There's an assortment of antibiotics that we use for pyelonephritis or UTIs. Ciprofloxacin is one. Bactrim or trimethoprim sulfamethoxazole is another. Okay. So really the prevention of infection is so that you don't worsen kidney function. Okay. Next one, the prevention of constipation. I don't really have much to say for that one. I'm not really clear on how that applies to polycystic kidney disease. I think prevention of constipation is probably a good idea for anyone. So, adequate oral intake, increasing dietary fiber, making sure that someone is mobilized. All those are good. Sometimes they need stool softeners such as docusate, which is a stool softener. But in relation to polycystic kidney disease, I'm having some difficulty connecting that. Patient education is really important. So in terms of monitoring their blood pressure and reporting if their blood pressure is poorly controlled, monitoring their weight, because that's an indication of fluid volume. So if someone is gaining 2 pounds every day, that's an indication that something is going really wrong with their kidneys. Okay. Contacting the healthcare provider for fevers or signs of infection, since it could be pyelonephritis. Okay. And also reducing sodium in the diet. Why? Because it makes you drink, right? And sodium also causes hypertension. And we don't want hypertension in polycystic kidney disease. Now, the last one, needle aspiration for chronic pain. I would think if someone had a large cyst from this disease and they were very uncomfortable, that could be an option to drain it. Okay, so if anyone's ever had an ovarian cyst, you may know how uncomfortable and painful those can be. So there's hundreds of these cysts on patients' kidneys, and some of them are filled with blood and very uncomfortable, and they can be aspirated. Okay, so let's do the questions at the back of chapter 59. So number 1, a nurse is planning care for a client who has pre-renal kidney injury following abdominal aortic aneurysm repair. Okay, so that's going to mean, so pre-renal injury to me means they were probably hypotensive either before the surgery or during the surgery. Urine output is 60 mils in the past 2 hours, so 30 mils an hour. And blood pressure is 92 on 58, which is on the low side. The nurse should expect which of the following interventions? Okay, prepare the client for CT with contrast dye. No, the contrast dye is only going to just hurt the kidneys further, and we don't need to image the kidneys, right? There's no need here. The issue is a pre-renal problem. Plan to administer nitroprusside. No, nitroprusside is a very powerful antihypertensive that's given IV, and it vasodilates all the blood vessels, causing more hypotension. This person does not need more hypotension. Prepare to administer a fluid challenge. There you go. Give them fluids to water the kidneys and increase the blood pressure. Plan to position the client in Trendelenburg. No, I don't think so. They don't need to be in Trendelenburg. They may need to be supine if they're dizzy, and we can just lay them flat, but really the number one treatment here is IV fluids, C. 2, a nurse is planning care for a client who has post-renal acute kidney injury due to metastatic cancer. So sometimes cancers, in particular in women, cervical cancer can spread to both ureters and block both ureters, which will result in a post-renal injury because both ureters are completely blocked from the cancer and there's no flow of urine, which is going to back up to the kidneys and cause post-renal failure. The client has a blood creatinine of 5. Okay, that's elevated. Usually creatinine is 0.6 to 1.2. Which of the following interventions should the nurse include in the plan? Provide a high-protein diet. Well, so in terms of a high-protein diet, I don't really like this answer, but in the setting of acute kidney injury, could you give a higher protein diet? I guess so. But what's it really accomplishing here? In surgery or with dialysis, you may need a higher protein diet, but that's not mentioned here. The only thing I can think of is this person has metastatic cancer and they may need more protein in their diet. I don't like that answer. Okay, because typically in chronic kidney disease, you have a low protein diet. So I'm not sure why they're asking you to choose provide a high protein diet. Anyways, there you go. Assess the urine for blood. Sure. We can definitely look at the urine to see if there's blood leaking from the metastatic cancer that's affecting the renal system. Monitor for intermittent anuria. My goodness, I really don't like this question. So monitoring for anuria is really important because anuria is telling us you don't have a urine output. You're not making any urine. And that's concerning because if they're not making urine, it means the kidneys aren't filtering the blood, which means the patient is going to get into trouble with all the things that occur with renal failure: volume overload, hypertension, hyperkalemia, right? Weigh the client once per week. Nah, you'd probably want to do it a bit more regularly than once per week. Okay, that would probably be a daily check because it's just such an accurate marker of fluid retention when someone gains weight. Provide NSAIDs for pain. Definitely not. We wouldn't give NSAIDs for acute kidney injury or chronic kidney injury. So I don't like this question. I think B is totally fine as an answer. C is fine as an answer, but I don't really like A. just confusing to me. So they're stating A, B, and C. I'm going to tell you when I don't really like a question, and there's a number of ATI questions that I don't like. Okay, number 3. A nurse is planning care for a client who has stage 4 chronic kidney disease. Which of the following actions should the nurse include in the plan of care? Assess for jugular venous distension. So stage 4 kidney disease is really just telling me they have a really poor filtering ability of the kidney. The kidneys are getting weak. They're going to become fluid overloaded. I'm going to check for fluid distension by looking at, or fluid accumulation by looking at venous distension. So yes, A. Provide frequent mouth rinses. Well, in chronic renal failure, you can have bad breath, so halitosis. So you could provide frequent mouth care. I don't think that one's unreasonable. Auscultate for a pleural friction rub. So we haven't spoken about this, but patients with renal failure can actually develop pleural effusions, so collections of fluid outside of the lung, and they can actually develop pericardial effusions, so accumulation of fluid around the heart. Okay, so auscultation for a pleural friction rub would be an answer. Okay, it does not assess, like it says in the answer, friction rub does not assess renal respiratory failure or pulmonary edema. Okay, so the reasoning C is correct is not accurate when you look at the answers. Provide a high sodium diet. No, that's going to cause patients to drink more. So low sodium diet also going to cause hypertension as well. Monitor for dysrhythmias, absolutely, because of the potassium. Okay, so A is definitely correct. B is correct, but it's okay. C, pleural friction rubs, yes, because they can develop pleural effusions and pericardial effusions. And E. Okay. Number 4, nurses reviewing client laboratory data. Which of the following findings is expected for a client who has stage 4 kidney disease? So blood urea 15 milligrams per deciliter. Okay. GFR of 20. Yes, that would be. So blood urea nitrogen can go up and down. I mentioned this before. So it can be really high if you become dehydrated or if you have a GI bleed. So it's a variable number. It is a marker of kidney disease, but creatinine is much more accurate. But GFR is the most accurate here. Okay, so a GFR of 20 is telling you it's stage 4 chronic kidney disease. Blood creatinine is 1.1. No, that wouldn't be the case. That wouldn't be the answer. And blood potassium of 5. That's not necessarily telling you what the stage of the kidney disease is at. It's just telling you what the potassium is at. Okay, so because the stages of kidney disease are based on GFR, that's the one that you would choose. GFR of 20 milliliters per minute. Okay, number 5. A nurse is assessing a client who has pre-renal AKI. Which of the following findings should the nurse expect? Reduced BUN. No, BUN should be increased, right? So if you have a GI bleed or you're hypotensive or dehydrated, your BUN is going to climb fast because it's not able to clear the urea from the kidney. Elevated cardiac enzymes, not necessarily. Right? Cardiac enzymes, when they're elevated, indicate a heart attack. Reduced urine output, yes, right? Pre-renal failure results in the kidneys saying, I better keep all the fluids in my body, so I'm going to reabsorb. So it's going to reduce urine output. And because the kidney's failing in this case, it's not making as much urine, so that's going to cause oligouria as well. Elevated blood creatinine, absolutely. right? Kidneys are failing, creatinine's building up in the bloodstream. Elevated blood calcium, no, that's not a finding in acute kidney injury. So it's going to be C and D. Okay. Okay, so let's talk about infections of the urinary tract. Okay, and when I think of the urinary tract, I think of the kidneys, the ureters, the bladder, and the urethra. Where do we typically get infections? Well, we can get infections of the kidneys themselves. That's pyelonephritis. We can get an infection of the bladder. That's cystitis. And an infection of the urethra called urethritis. So urethritis, by the way, is typically a sexually transmitted disease such as chlamydia or gonorrhea. Okay. Just a very quick review here. What do the kidneys do? I know this is repetition, but maintaining fluid volume in the body, removing waste such as BUN, creatinine, and other toxic waste from the blood, regulation of blood pressure through the renin-angiotensin aldosterone system, maintaining proper acid base of the bloodstream, producing erythropoietin so we don't become anemic, right? Stimulates RBC production, and activation of inactive vitamin D, which is produced in the skin with exposure to sunlight or through dietary intake of inactive vitamin D. Active vitamin D is called calciferol, and that is what the kidney activates, right? So it activates inactive vitamin D, called cholecalciferol, to active vitamin D called, calcitriol is active vitamin D, okay? Okay, so we're going to talk about different areas that develop infection in the system. So when we're talking about lower urinary tract infections, we're typically referring to infections of the bladder. And by the way, we're typically talking about bacteria, right? So cystitis is usually caused by a bacteria. Urethritis, which I mentioned is an STD, is typically caused by a bacteria, such as chlamydia or gonorrhea. Okay. In men, prostatitis can occur, which is a bacterial infection, typically of the prostate. And men can actually become quite ill with prostatitis. They can have fevers, they can have pain in their perineum, which is right behind their scrotum. So it's a pretty uncomfortable condition to have. Okay. So what are symptoms of cystitis? So the bladder. Well, you're going to go to the washroom more frequently. You're going to have urgency, meaning when you have to urinate right now. And you're going to have dysuria, which is painful urination. Okay. Urethritis has similar symptoms. When the person urinates, they have painful urination. They don't usually have the frequency and the urgency because it's not within their bladder. It's just within the urethra. So when they urinate, they feel that burning. Okay. As well with urethritis, you can have a clear mucousy discharge with chlamydia, or you can have a purulent pussy discharge with gonorrhea. Okay. An upper UTI refers to a pyelonephritis, which is a infection of the kidney tissue itself. Okay. Many UTIs, whether it's pyelonephritis or cystitis, are caused by an assortment of different bacteria. A common one is E. coli. Other ones, such as Klebsiella, very frequently cause UTIs. Okay. So an untreated cystitis, for example, can result in an infection that goes upwards and causes a pyelonephritis. Okay, so that's how most pyelonephritis are caused, by originally having a cystitis that then ascended and infected the kidney. Okay, and if the kidney gets infected, which is called pyelonephritis, and then starts to leak bacteria into the bloodstream, we call that bacteremia. And if the bacteremia causes a systemic inflammatory condition, we call it sepsis. Okay, and of course, sepsis will lead to unstable vital signs, hypotension, tachycardia, and potentially death. Okay, so that's the condition called urosepsis. So let's just briefly look at some risk factors for developing a urinary tract infection. So when I say urinary tract infection, that's going to be either cystitis or pyelonephritis. Okay, we'll leave prostatitis out of it, and we'll leave urethritis out of it for now because that's an STD. Okay, so bacteria are happy to grow in urine that tends to be more alkaline, so a higher pH. And that's partly why we give acidic solutions such as cranberry juice or vitamin C to try and prevent bladder infections, right? Because it makes the urine acidic. Catheters. So someone who has an indwelling catheter, a Foley catheter, is at high risk for developing a bladder infection or a pyelonephritis because there's a foreign object in their bladder. Stool incontinence, because the perineum is now contaminated and the bacteria can ascend into the bladder, causing either a cystitis or, if it goes even higher, a pyelonephritis. Bladder distension, that kind of refers to someone who's not really emptying their bladder. So, for example, a male with BPH or a patient with a spinal cord injury that's not emptying their bladder properly, and they constantly have a bit of urine in their bladder, and finally it gets infected and causes a cystitis or a pyelonephritis. And we see old men frequently with BPH that develop recurrent bladder infections because they're not fully emptying their bladder any longer. Okay. And another one is diabetes. Diabetes causes some sugar to leak into the urine from the bloodstream, especially if it's poorly controlled. And because of that, bacteria are more prone to grow within the urinary system because there's sugar there that they can feed off of. Okay. Definitely women are at higher risk for UTIs than men. Okay. Because the distance between the outside world and inside the bladder with a short urethra is very small. So women are more prone to cystitis in particular. Okay. As women go through menopause, estrogen, which typically promotes healthy tissue in the genitalia, estrogen disappears, and so they get atrophy. And so atrophy of tissue is thinning of tissue, and the urethra is part of that. So not only can they get vaginal atrophy and vaginal dryness, but they can have urethral atrophy, which makes them more prone to bacteria getting into the bladder. Okay, so menopause is a risk factor for cystitis or urinary tract infections. Sexual intercourse, just because of the movement, can cause bacteria to ascend into the bladder of a female. Okay. Pregnancy is a risk factor. Okay, women that are pregnant are slightly immunocompromised. Okay, so because of that, they're more prone to UTIs, and UTIs in pregnancy can be serious. Okay, so we frequently check women's urine to rule out the potential for UTIs. Okay. Well, the other ones are pretty clear. Wearing wet bathing suits, frequent submersion in baths or hot tubs. I think that's pretty clear, especially for females. In males, okay, sorry, in males, the biggest risk factor is incomplete emptying of the bladder. Okay, and that's typically from BPH. Okay, it's uncommon for males to get UTIs. Otherwise, because of the longer urethra, it's much more difficult for bacteria to get into the penile urethra and ascend into the bladder. Okay, so risk factors we covered, we just spoke about. So females are at higher risk, especially for cystitis that, if not treated or just sometimes spontaneously, can turn into a pyelonephritis, which is much more serious. Catheters, stool incontinence, bladder distension, that's more common in males, but say they had a spinal cord injury or incomplete emptying of their bladder from a disease. Diabetics and older clients. So why are older clients risk factors? Well, older patients, when they get a simple bladder infection, it can cause them to be utterly confused. So not only do they get the typical frequency of urination, the painful urination, and the urgency to urinate, but in older patients, a UTI, just a simple bladder infection, can cause them to be acutely confused. Okay, and that's different than a younger patient. It doesn't do that in a young patient. Remember, in a bladder infection, you never ever have a fever. So a fever that's associated with a UTI is typically a pyelonephritis. Okay, it's an infection of the kidney, not the bladder itself. Okay, so just remember that bladder infections never cause a fever. Okay, expected findings. So some people, especially women, can be asymptomatic, and in particular, pregnant women can be asymptomatic and what we call asymptomatic bacteriuria. So they have bacteria growing in their bladder, but they're asymptomatic. And that is partly why we check women's urine when they're pregnant to see if they're growing bacteria in their bladder. Why do we do that? Because we don't want them to get an ascending infection, which results in a pyelonephritis, which is much more serious. Okay. Okay, so let's look at some other findings. So lower abdominal pain and lower back pain is pretty typical for just a bladder infection, a cystitis. Flank pain, or what we call costovertebral pain, which is in the just below the ribs on each side of the back, costovertebral angle discomfort, is typical for a pyelonephritis. Okay, burning upon urination, that could be cystitis, or that could be associated with a pyelonephritis. Okay, frequency and urgency I mentioned, that could just be a simple bladder infection, or that could be as part of a constellation of having pyelonephritis. Remember, pyelonephritis typically occurs secondary to having a simple cystitis, right? So they have the same symptoms plus more. They have that flank pain, they have fever, they have an elevated white blood cell count, they're sicker. Sometimes they need hospitalization for IV antibiotics because they're significantly more ill, and some people can develop urosepsis secondary to pyelonephritis. Okay, urinary retention can occur in a bad cystitis. Okay, especially in men, they can go into urinary retention. So if we put a Foley catheter in, we do a urine sample, and we realize, oh, they have a bladder infection and they're unable to urinate because of it. Not very common. The other symptoms are much more common. Some people come in and say, I'm urinating a bit of blood. right? So hematuria is quite common with either a cystitis or a pyelonephritis. Nocturia is getting up through the night, and that's just because the bladder is irritated, and they have to get up and empty their bladder because the bladder can't hold very much urine because it's so irritated. Foul smelling or cloudy urine is sometimes reported by patients for sure. Okay, in older adults, this can occur. So confusion and delirium, incontinence, that can occur in just a simple bladder infection. So that's the difference between an old person with a bladder infection and a young person. A young person comes in and says, I've got some really painful burning. I'm super uncomfortable in my lower abdomen. I have urgency, I have frequency, but they're not confused at all. They don't have a fever, and they're certainly not delirious. An older person can have all of the symptoms that the younger person has, plus confusion. They've suddenly become incontinent. They can't hold their urine any longer. Okay. Hypotension, tachycardia, tachypnea, and fever. Okay, now we're talking about pyelonephritis that's now seeding the bloodstream and causing urosepsis. Okay, so it's gone from the bladder, and then it caused pyelonephritis, so that now they would have flank pain and fevers, and then it's gone into the bloodstream and caused urosepsis. Okay, so this slide's on catheter-associated urinary tract infection prevention, and this is really important because urinary tract infections are a big thing in hospital, and we're always looking for ways to prevent them. In the past, we used to put a Foley catheter in almost everyone that got hospitalized, and now we're much more careful because of the increased risk of causing a cystitis or a pyelonephritis secondary to the catheter. So I would read through these bullet points. I'm not going to go through them all, but they're just ways of preventing an infection with a urinary catheter. And the biggest one to ask is, does this person really need a catheter? Okay. Many patients that have a Foley catheter don't actually need one. It just makes life a bit easier in the hospital for the hospital staff, but it can make life miserable for the patient if they get a cystitis or a pyelonephritis. Okay, so I would go through these bullet points. I think they're useful, but in the interest of time, I'm going to keep on going. Okay, so UTI diagnostics. Okay, we want a urinalysis to look and see what is in the urine, right? And with a urine infection, we're expecting to see potentially white blood cells, red blood cells because of the infection, bacteria, if we were to look at it under the microscope, a positive leukocyte esterase, and nitrates. Those are really accurate on the urinalysis dipstick. Okay. So don't forget getting the proper technique to collect the urine. So we want a midstream urine from either a woman or a man so that we can send it off for a culture in sensitivity. Okay. If we don't get a midstream urine, it's likely going to be contaminated, and when we send it off for a culture, it'll likely be positive, but it won't help us in terms of treating the UTI if we needed to alter the antibiotics based on the sensitivity that we get back. Okay, so we need a really good midstream urine catch. Okay, elevated white blood cell count. So an elevated white blood cell count will occur in a pyelonephritis or if they have urosepsis. Okay, so I just think of pyelonephritis as, yep, that's a pretty bad infection of the kidney. That's going to cause a systemic response, including an elevated white blood cell count and an elevated neutrophil count, since it's bacterial. With urosepsis, absolutely. Again, you're going to have a elevated white blood cell count, often with increased neutrophils that we call a left shift. So a left shift just means there's immature neutrophils that are leaving the bone marrow to fight the infection. Okay. Sexually transmitted testing. So that's where I mentioned for symptoms of urethritis. So I have burning on urination, and we check the urine. We don't see too much in the urine, so we're not suspecting a bladder infection. But the patient continues to complain of burning with urination, and so we can check for chlamydia and gonorrhea. Okay, those are the two most common causes of acute urethritis. Okay, diagnostic procedures. So for the most part, bladder infections, meaning cystitis, we just treat them, right? We treat them with antibiotics. We don't typically do a cystoscopy for a bladder infection unless it's recurrent. So someone who's coming back over and over and over again for a cystitis, then it's worthwhile looking into the bladder to see if there's something within the bladder predisposing the person to recurrent bladder infections. Okay. A pyelonephritis we usually diagnose clinically. Flank pain, fevers, elevated white blood cell count, ill-appearing person, urine positive for white blood cells, red blood cells, leukocyte esterase, nitrates, plus they have the symptoms of a urinary tract infection, dysuria, frequency, and urgency. So usually it's a clinical diagnosis. If we want to look at the kidney, we can do a CAT scan. Don't forget that's significant radiation for doing a CAT scan, especially in a young person. Or we do an ultrasound to look at the kidneys, which is a really accurate test for looking at the kidneys. Okay. Okay, so let's look at some interventions for a UTI. And it differs a bit depending on if it's a simple cystitis, which is basically drink lots of fluids, take your antibiotics, and usually in 1 to 2 days you're feeling significantly better. Make sure you finish your course of antibiotics. We've taken a urinalysis that shows white blood cells, blood, positive leukocyte esterase, and nitrates. And we're going to send your urine off for a culture in sensitivity. Okay, so a simple cystitis is relatively simple to treat. Okay, and most patients get better with a 3, 5, or 7-day course of antibiotics. Okay, so what kind of antibiotics do we use? Well, there's a group called the fluoroquinolones that we frequently use, such as ciprofloxacin, norfloxacin. There's a number in that. There's 4 or 5 in that group. Another one's called levofloxacin. They're all basically around the same. The big issue with the fluoroquinolones is in older patients they can cause confusion, and in anybody they can cause tendinopathies and tendon rupture. Okay. On top of that, they prolong the QT on the ECG that can lead to torsade de pointes. Okay. Nitrofurantoin, another commonly used antibiotic for a bladder infection. Okay. Trimethoprim is often combined with a sulfa antibiotic, so it's trimethoprim slash sulfamethoxazole, which is also called Bactrim. A very common combination antibiotic used in UTIs. Okay, but there's an assortment of other antibiotics that we can also use in UTIs. When we're talking about nitrofurantoin, we only use it for a cystitis. We don't use it for a pyelonephritis because it's not really concentrated well in the kidney. And also it's bacteriostatic. It's not bactericidal. So we use nitrofurantoin only for cystitis. Okay. Now, if trimethoprim sulfamethoxazole is used, we definitely check if the patient has a sulfa allergy, because one of the antibiotics, the sulfamethoxazole, is a sulfa-based antibiotic. And the concern with sulfa antibiotics, such as the one I'm talking about, is the potential. It's a small potential, but the potential to cause a Stevens-Johnson type rash. Okay, so that's always a small concern in the background. We still use it for urinary tract infections such as cystitis or pyelonephritis. But if you've seen Stevens-Johnson syndrome once or twice from sulfa antibiotics, then it makes you a bit more concerned to use them. Okay. The other issue with sulfamethoxazole, again, the sulfa antibiotics or any sulfa-based drug, is photosensitivity. They can get a rash when they're out in the sunlight. Okay. We advise patients to drink full glass of water and to increase fluid intake with any of these antibiotics to get them into the urinary system, through the kidneys, and into the bladder. Okay. Another drug that's used in combination with an antibiotic for cystitis is phenazopyridine, which is a urinary analgesic. It's not to treat the bladder infection. It's to numb the bladder wall and the urethra. And it's very, very popular with women that get recurrent UTIs or just get UTIs because it takes the pain away within hours. Okay, so it's a urinary analgesic. It turns any fluid from the body orange. So, for example, if you have tears, they might be orange. If you have contact lenses in, they're going to turn orange. It turns the urine orange as well. Okay. Very effective, and often it's started when the antibiotic is started, and once the painful urination goes away, then you can stop the phenazopyridine because that's all it was used for. Okay, so definitely helps with dysuria. So monitoring for complications. So if someone has a simple bladder infection, we know the symptoms: dysuria, frequency, urgency, lower abdominal discomfort, maybe some lower back pain. Maybe they have a bit of hematuria, but they're not febrile and they don't look terribly ill, unless it's an older person that gets confused or a bit delirious. Okay. Monitoring for complications is the development of pyelonephritis from the cystitis. So now we're looking at flank pain, fever, elevated white blood cell count, potentially a sick person now, and that can spill over into the bloodstream, leading to urosepsis. And now we're getting into symptoms and signs such as hypotension, weakness, tachycardia, and that can cause septic shock, which is just a worsening of the urosepsis. Okay, so these people can get really ill if this bacteria gets into the bloodstream and sets up sepsis. So usually a bladder infection is going home with a prescription for an antibiotic and maybe some phenazopyridine. Pyelonephritis just depends on how sick the person looks. So if they look quite well and they're younger and their vital signs are stable, they can go home with a prescription for antibiotic and a follow-up to make sure that they're improving. Okay. Urosepsis or septic shock is they're definitely staying in hospital because they have unstable vital signs secondary to the pyelonephritis because the bacteria has gone into the bloodstream. Okay, so they need IV antibiotics. They often need an intensive care. Sometimes they need blood pressure support with IV fluids and vasopressors to keep their blood pressure controlled. Okay. Okay, so patient education. So the first one I want to mention is avoid indwelling catheters if possible. Okay, this really reduces the risk of creating a UTI when one didn't need to happen. So we really think about indwelling catheters in hospitals now. Okay, someone who's pregnant and develops a UTI needs to be monitored quite closely because a cystitis in a pregnant woman can turn into pyelonephritis, and pyelonephritis in a woman can cause preterm labor. Okay, so we take pyelonephritis in pregnancy seriously, and they typically get admitted to hospital for IV antibiotics. Okay, always remind the patient to finish the entire course of the antibiotics. Otherwise, there's a potential for return of infection. Okay. Some medications are taken with food. It's hard to kind of pinpoint that one since others aren't. But one thing is clear with urinary tract infections is increase fluid intake. Okay, get this antibiotic to the urinary system by increasing your fluid intake. Okay, if you were to develop an adverse effect such as diarrhea from the antibiotic, report it to the healthcare provider since there's a risk of developing Clostridium difficile. So what other education? So I mentioned the increasing the fluid intake, 2-3 liters daily, especially during a UTI. You want to increase it, so 3 liters a day. Urinating before and after intercourse for women that get recurrent UTIs is a good idea. It actually prevents the development of a UTI. Some women actually have to take an antibiotic after intercourse because they get such frequent UTIs with intercourse. Okay. Drinking cranberry juice does not treat a UTI. It reduces the chance of getting a UTI because cranberry juice has vitamin C in it, and when you make the urine acidic, bacteria are less prone to grow. Proper instructions for females is important. So wiping from front to back. Okay, so in young girls that are learning how to properly clean themselves, that's important. Especially if they've had UTIs, they need to learn how to wipe properly from front to back. Okay, avoiding bubble baths and feminine products, they increase the risk of bladder infections. Okay, and bubble baths irritate the perineum and the urethra. Okay, sitting in wet bathing suits. Okay, this probably applies more to young girls. That makes them more prone to getting UTIs. So avoid staying in a wet bathing suit. Okay. Tight, constricting clothing or clothing that can cause moisture and sweating should also be avoided in females. Okay. Now, some women get such frequent UTIs that they require a preventative doses of antibiotics to stop the UTIs. So, for example, a female that's getting recurrent UTIs every month and is getting full courses of antibiotics every month, they can go on a small dose of antibiotics weekly to prevent the UTI in the first place. Okay, so that's for chronic UTIs. Okay, so prophylactic antibiotics for prevention of frequent UTIs. Okay, so we've covered most of this on the slide above in terms of females on the left there. In the middle where it says everyone, so Urinate after intercourse, that's definitely more important in females because of their short urethra and they're so prone to developing bladder infections. Emptying your bladder every 3 to 4 hours, that would apply to everyone. Avoiding tight clothing is a good idea. Proper hygiene, so showering or bathing. Diet, so increasing fluid intake. So increasing your fluid intake makes more urine flow, which prevents urinary tract infections. Cranberry juice, or basically anything that's high in vitamin C can also make the urine acidic and prevent UTIs. Okay. The bottom here, coffee, tea, citrus, fruits and juices, spices, sodas, alcohol, those are all bladder irritants. Okay, so if you already have an irritated bladder from a cystitis, these would be products to avoid. Okay. Okay, so pyelonephritis is a bacterial infection, typically, um, and inflammation of the kidney. Okay, and it occurs from an ascending infection from the bladder. So you typically begin with a bladder infection from the bacteria, and the bacteria ascend up the ureter and get into the kidney, leading to a pyelonephritis. E. coli is definitely a common cause of pyelonephritis. There's other ones as well, Pseudomonas, Klebsiella. There's a number of bacteria that are responsible for causing pyelonephritis. Now, if you get recurrent pyelonephritis, so recurrent bacterial infection of the kidney, it can result in scarring and fibrosis of the kidney, which is going to harm the nephrons. And over time, if you get repeated attacks of pyelonephritis, you can be left with decreased kidney function, which can lead to chronic renal failure. Okay? Now, one bout or 2 bouts of pyelonephritis are not usually going to result in chronic renal failure. But a child who starts to develop pyelonephritis and continues to get them through childhood and adolescence, well, they can be left with scarring of their kidneys and chronic renal failure. Okay? So when we use the term acute pyelonephritis, we're referring to an acute bacterial infection of one of the kidneys. And typically, it's a female that's going to get pyelonephritis because they're the ones that get cystitis, right? And as I mentioned before, one bout of pyelonephritis is not going to lead to chronic renal failure. And how do we treat pyelonephritis, acute pyelonephritis? With oral antibiotics, or if the patient's really ill, IV antibiotics, plus oral fluids, so increasing oral fluid intake, or IV fluids if they're not able to drink oral fluids. Okay. Chronic pyelonephritis is repeated infections leading to scarring and fibrosis of the kidney. Okay, and these are patients that can be left with chronic renal failure because of the damage from the repeated infections. So what are risk factors for developing pyelonephritis? Well, definitely being a female is a risk factor because they're the ones that get cystitis. Okay. What's another risk factor? Well, in males, it's having BPH. So if you have BPH, you have incomplete emptying of the bladder because of the benign prostatic hypertrophy that results in stasis of urine in the bladder that can get infected and get into the kidneys, causing pyelonephritis. Okay. Urinary stones, so kidney stones that are blocking the ureter, well, they're going to block urine flow from leaving the kidney, and that can back up and cause pyelonephritis. Pregnancy, okay, so women is a risk factor. Pregnancy is definitely a risk factor. As the uterus gets bigger, it's actually compressing the ureters. And when you put a bit of pressure on the ureters, you're reducing urine flow to get to the bladder. That can result in pyelonephritis. Okay, anybody who has a congenital malformation of the kidneys or the ureters or the bladder can have an abnormal flow of urine, and some of it, for example, can reflux back into the kidney, leading to pyelonephritis. Okay. I think that's it. Incomplete bladder emptying, that's going to be BPH in males, okay, or a spinal cord injury in either females or males. Okay, I think that's it. So what are the findings of pyelonephritis? So typically you have flank pain. So unilateral flank pain. So depending on if it's a left pyelonephritis or a right pyelonephritis. So it's right in the costovertebral angle, which we call flank pain. Okay. Often you'll have fevers and chills. You'll have nausea and vomiting. People come in with malaise. They're not feeling well. They're ill appearing. And on top of that, they have all the symptoms of the cystitis that started the whole thing. The burning, urgency, and frequency of urination, right? They can have unstable vital signs. They can be tachycardic. They can actually be hypotensive if the pyelonephritis is now causing them to be septic, okay? So if I'm seeing someone with pyelonephritis, they're usually telling me that they feel unwell, they're nauseated, they have fevers, chills, and the shakes. They have costovertebral flank pain. If I were to percuss the area of their back, it's painful to palpation or percussion. And they also tell me that they have dysuria, frequency, and urgency. Okay. So what about the laboratory tests? Well, it's going to the urinalysis, which is the quick dipstick. We mentioned before, can have white blood cells, red blood cells, positive leukocyte esterase, and positive nitrites. The urine culture that we send off typically takes a few days to get back, so we've already started the antibiotics after obtaining the culture. And we wait to see what grows on the culture and if we selected the appropriate antibiotic, because we get a sensitivity back as well. Sometimes if someone is quite ill appearing with a pyelonephritis, we'll do blood cultures because they may be bacteremic or septic, and we'll wait for blood cultures to come back to see if anything is growing in the bloodstream. In terms of creatinine and BUN, it's not typically elevated. I mentioned before that acute pyelonephritis is a condition of one kidney. So the other kidney more than makes up and maintains a normal BUN and creatinine. So in your book, I don't think that's really accurate. With chronic pyelonephritis that's harmed both kidneys over time with repeated infections, then you can have an elevation of your BUN and creatinine. But with just one episode of acute pyelonephritis, you wouldn't have an elevation of your BUN and creatinine typically. ESR or CRP are typically elevated because this is an inflammatory process due to the infection, right? So they'd both be elevated in a pyelonephritis. Okay, so let's just briefly talk about interventions for pyelonephritis. I know there is some repetition in these PowerPoints, but it's for you to really get a good understanding. So I apologize for the length of time. Okay, so assessing these patients with pyelonephritis, assuming they get admitted to a hospital. So input and output, very important, right? They have a kidney infection. So if they're admitted to hospitals, it's usually because they're quite ill. Otherwise, they would have gone home with oral antibiotics. So ins and outs are really important. Fluid and electrolyte balance, typically because if they're in hospital, they're on intravenous fluids initially, often because they're nauseated and vomiting. So we need to monitor the input of fluid, the rate of how much fluid we're giving, and checking their electrolytes, typically daily. Okay? Monitoring vital signs. Some of these patients with pyelonephritis can become septic, so vital signs are really important. And that would include temperature, of course. Monitoring for pain. A lot of patients have costovertebral angle discomfort and pain with this illness. Surgical dressings, that would be really uncommon in pyelonephritis unless there's something that's blocking the ureter, which is causing the pyelonephritis, such as a kidney stone. Most patients with pyelonephritis do not need a surgical procedure. Okay. Monitoring for complications, I mentioned. So if we think someone has septic shock, it will be based on vital signs and how ill they are. So hypotension, tachycardia, confusion, weakness, okay, chills, rigors, and we'll take blood cultures. We'll take a CBC in any pyelonephritis, looking at their white count. CRP and ESR are invariably elevated in this condition because it's infectious and inflammatory. And with repeated bouts of pyelonephritis, you can develop chronic kidney disease. As I mentioned before, not with one episode of pyelonephritis. We always take a urinalysis, and typically we find white blood cells, red blood cells, positive leukocyte esterase, and nitrites. And we send it off for a urine culture, which is going to help guide us with antibiotics. Sometimes we need to change the antibiotics if initially we chose the incorrect one and the bacteria isn't sensitive to it. Monitoring creatinine and BUN is important. As I mentioned before, typically they're normal since one kidney is affected. Okay. Most people with acute pyelonephritis do not have hypertension. If you have multiple bouts of pyelonephritis and you develop chronic kidney disease, then you could develop hypertension, but not with one bout of pyelonephritis. Okay. Diet, well, just depends if they're able to eat or not. If they're vomiting, then they're on IV fluids. If they're not vomiting, maintaining adequate nutrition because they have an infection, and also encouraging fluid intake to stay hydrated and also to get the antibiotic to the kidney. Administration of medications, so antipyretics for fevers, analgesics for the pain. Often we'll get away with just acetaminophen. If they have severe pain, sometimes we'll have to use an opioid analgesic. Antibiotics, often they're oral. If the patient has stable vital signs, they look quite well and they're able to go home. If they're ill, hypotensive, chills, rigors, then they need to come into hospital for IV antibiotics, typically 1, 2, or 3 days, and then we switch them over to oral antibiotics. Okay. In terms of therapeutic procedures, for the vast majority of people with acute pyelonephritis, they just need what we spoke about. But if they have a stone that's blocking the ureter, well, that stone needs to be dealt with so urine can flow again. Okay. Nephrectomy, which is removal of the kidney, would be very unusual in a pyelonephritis, since with the antibiotics that are available, we typically clear the infection. Okay. Okay, so let's briefly talk about glomerulonephritis, which is an inflammatory condition of the kidney, and it's not infectious typically. Okay, there's no bacteria or viruses or anything that are affecting the kidney, and it's usually an immune-mediated condition where antibodies attack the glomeruli and damage the nephrons. Okay, so other diseases can lead to glomerulonephritis, such as systemic lupus erythematosus. Diabetes causes glomerular injury, and they start to leak protein into their urine. That can take years to occur with diabetes. So don't think of glomerulonephritis as an infectious disease of the kidney. Now, sometimes an infection such as strep throat can lead to glomerulonephritis, but it's not the bacteria in the strep throat that's traveling to the kidneys. It's the antibody response to the strep throat that then causes glomerulonephritis, which is inflammation of the kidneys. Okay. So as I mentioned, so when it says recent infection as a risk factor, we're typically thinking of streptococcal pharyngitis causing glomerulonephritis. The presence of systemic diseases, we're thinking of diseases such as lupus that, as part of the illness, produce antibodies that affect the glomerulus. Okay, and also I mentioned diabetes, but there's many types of glomerulonephritis, and they're typically caused by either auto antibodies or some kind of immunologic attack on the kidneys. An example would be a condition called Goodpasture's syndrome, which is an autoimmune disease that specifically attacks the kidneys and leads to glomerulonephritis, which is basically just inflammation of the glomerulus. Okay, so what are the findings in glomerulonephritis? Well, the kidneys are being injured by this immune-mediated attack on them. Okay, so anorexia and nausea, okay, that can happen in almost any illness. So lack of appetite and nausea, sure. Dysuria, I wouldn't say is a common sign of glomerulonephritis. Okay, that's a common sign of cystitis or urethritis. Fatigue, because the kidneys are being attacked and there's starting to be a buildup of BUN and creatinine and other toxins in the bloodstream. Hypertension, again, kidneys are being attacked by these antibodies and they're not regulating blood pressure anymore, and it leads to hypertension. Dyspnea, because of fluid overload. The kidneys are starting to fail. So you get shortness of breath because of the volume overload. And cola-colored urine, because in glomerulonephritis, you're leaking red blood cells across the damaged glomeruli, and they're appearing in the urine, and we call it cola-colored urine. As well, since there's volume overload, patients often present also with weight gain, and they can have edema, okay, because they're not getting rid of the volume of fluid that they're supposed to. Okay, so laboratory tests in glomerulonephritis. Well, the kidneys are under attack by antibodies and they're reducing function. So let's just look at the urine first. So in the urine, in glomerulonephritis, remember those glomeruli are becoming damaged with inflammation from these antibodies, and they're leaking red blood cells and leaking protein into the urine. And we'll pick it up on a urinalysis. Remember, on a urine culture, it'll be negative. This is not a bacterial infection. Okay? Decreased glomerular filtration rate because the glomeruli are being damaged and destroyed. Okay? What about a 24-hour urine test? Well, we're likely going to see increased protein, but not to the same degree as in nephrotic syndrome. And we're going to talk about nephrotic syndrome, where you lose tremendous amounts of protein. Okay, so 24-hour urine testing for glomerulonephritis wouldn't be overly helpful. BUN and creatinine will be elevated, right, because the kidneys are being injured. As the kidneys are injured, guess what goes up? Potassium, phosphate goes up. Calcium tends to drop. Why? Because the kidneys are no longer activating vitamin D. So you can get hypocalcemia, right? And really, the diagnostic test for glomerulonephritis is a kidney biopsy. That's how we determine what is going on in the glomeruli, what is damaging these glomeruli. And the kidney biopsy tells us that. We send it to pathology, and they look at the underlying pathology inside the kidney. Now, if the cause is from strep throat, then we can check for antibodies that are reacting to the strep throat and also causing glomerulonephritis. And they're called anti-streptolysin antibodies or titers. Okay. If we think someone has lupus nephritis or lupus glomerulonephritis, we can do an anti-nuclear antibody test, which is a test for lupus, ANA. Okay. All right. Let's go on. Okay, so interventions for glomerulonephritis. Well, the first one makes sense because there's the kidneys under attack by these antibodies, and the patient can be quite fatigued. So conservation of energy would be important. Assessing the need for fluid restriction because the kidneys aren't filtering as well since the glomeruli are being destroyed, so they can become fluid overloaded, such as peripheral edema, shortness of breath because they have fluid in their lungs, and crackles on auscultation. Okay. Helping decrease patient stress. I won't get into that one. Monitoring for sure because they can develop severe hypertension. They can go into respiratory compromise because of fluid overload, right? So the fluid is backing up into the lungs and they're getting short of breath. So we're going to monitor respiratory rate, O2 saturation, monitoring fluid and electrolytes in the body since the kidneys are no longer filtering them properly. It can be a buildup of, in particular, potassium and a drop in calcium, for example. Administration of medication. So don't get confused here. Antibiotics would only be used, say, to treat the strep throat, okay, which will hopefully prevent the glomerulonephritis. We're not treating the glomerulonephritis with antibiotics, okay? So in actual fact, most glomerulonephritis we don't treat with antibiotics at all. It's only if it's been triggered by a bacterial infection such as strep throat. So we treat the strep throat in the hopes of the glomerulonephritis settling down. Okay. And lastly, antihypertensives, because of the fact that patients can become very hypertensive with glomerulonephritis. In fact, some patients with glomerulonephritis, because it's an inflammatory antibody-mediated disease, sometimes we'll put them on corticosteroids to directly treat the glomerulonephritis. I know that's not mentioned in your book, but I just don't want you to think that glomerulonephritis is an infection of the kidneys, because it's not. Okay, so nephrotic syndrome is a condition that also injures the glomerular membrane. So diseases that cause the glomerular membrane to become very leaky to proteins. So what's the defining factor about nephrotic syndrome is huge amounts of protein in the urine. And that's where we're going to do a 24-hour urine protein test to rule in or rule out nephrotic syndrome. And typically nephrotic syndrome, they're spilling 3.5 grams of protein in a 24-hour period into their urine. Okay. So what can cause nephrotic syndrome? Well, the big ones in the top left corner there will be diabetes mellitus. Okay. There's some other conditions. So lupus usually causes glomerulonephritis, right? Now, there are also conditions in children where they develop nephrotic syndrome. Okay, so what are the symptoms of nephrotic syndrome? Well, you're losing lots of protein in your urine, so massive amounts of proteinuria. Because you're losing protein, you're losing albumin, So you're going to lose oncotic pressure in your vascular system. You're going to have peripheral edema all over, in your hands, in your legs, around your eyes. We call that periorbital edema. And if we were to check albumin in the blood, they would be low. They would have a low serum albumin. The other manifestation of nephrotic syndrome is elevated lipids in the bloodstream. Okay, why do they have elevated lipids? Well, the liver is sensing that there is a low albumin, and the liver turns on to produce more albumin to make up for the loss. And while it's producing albumin, it also produces large quantities of lipids that go into the bloodstream. Okay, so that's the reason why in nephrotic syndrome you typically have elevated lipid levels as well. Okay, so medical management, it's treating the underlying cause, so finding out what's causing nephrotic syndrome, and sometimes that requires a kidney biopsy to diagnose the underlying condition. Okay, some patients can have a gradual progression to chronic kidney disease if the nephrotic syndrome is not well controlled. Okay, what other medications? So diuretics, because they have massive amounts of peripheral edema. ACE inhibitors can be used, since some people can have hypertension with nephrotic syndrome. And anti-lipid medication, because I mentioned elevated lipids frequently occurs in nephrotic syndrome. Okay, so I would see glomerulonephritis as different than nephrotic syndrome. Glomerulonephritis is inflammation of the glomerulus, causing a leaky glomeruli and red blood cells and protein leak across the membrane and get into the urine. Okay, and it's typically caused by an immune-mediated response. So it could be an autoimmune antibodies, or it could be immune-mediated in terms of someone has a strep throat and they get a secondary glomerulonephritis. Nephrotic syndrome is totally defined by protein loss in the urine. So think of them as different. Glomerulonephritis is an inflammatory condition. Nephrotic syndrome is just purely leaky glomeruli causing massive proteinuria. Okay, we're getting there. So the questions at the end of chapter 60. So number 1, a nurse is planning care for a client who has chronic pyelonephritis. Okay, which of the following actions should the nurse plan to take? So chronic pyelonephritis is usually due to repeated attacks of acute pyelonephritis, which has led to this condition called chronic pyelonephritis. Provide a referral for nutrition counseling. Yeah, that's a good idea, because chronic pyelonephritis, the patient's going to have chronic kidney disease. So they're going to need to avoid salty foods, decrease protein intake, potentially reduce fluid intake. Okay, encourage daily fluid intake of 1 liter. So 1 liter a day is very little fluid. Okay, when we're counseling a patient about fluid intake, we include all the fluids they're taking, whether it's in fruits, vegetables, fluids that they drink, tea, coffee, everything. 1 liter is very little. Okay, so we would not encourage a daily fluid intake of 1 liter. That's very low. Someone in congestive heart failure might be on 1.5 liters of fluid, otherwise they go into congestive heart failure, but not typically with chronic pyelonephritis. Palpate the costovertebral angle. Well, planning care. Okay, I'm not quite sure why you would palpate the costovertebral angle. You could, and they might be tender there, but I'm not sure how that comes into planning care for a client. I wouldn't choose that one. I don't think it's okay. You could do it. Maybe it's to check for acute pyelonephritis. I'm not sure on that one at all. Monitor urine output, absolutely. these patients can develop chronic renal failure. We want to know, are they producing proper amounts of fluid? Administration of antibiotics may be needed since pyelonephritis is a bacterial infection, right? So they may need repeated courses of antibiotics. So the answer is A, C, I'm not clear on that one at all, D, and E. Okay. Number 2, a nurse is caring for a client who has urinary tract infection. Which of the following is the priority intervention by the nurse? Offer a warm sitz bath, recommend drinking cranberry juice, encourage increased fluids, administer an antibiotic. Okay, so if we're looking at a urinary tract infection, it's definitely going to be administer an antibiotic, because urinary tract infections, whether it's a cystitis in the bladder or a pyelonephritis in the kidney, they're typically bacterial. Cranberry juice can be used to prevent bladder infections, not to treat them. Okay? Encourage increased fluids would be correct, it's just not the priority. Okay? Number 3, a nurse is preparing educational material to present to a female client who has frequent UTIs. Which of the following information should the nurse include? 5 answers here. Okay. Avoid sitting in a wet bathing suit. That's definitely a very good idea, not to sit in a wet bathing suit. B, wipe the perineal area back to front. No, that's going to increase bacterial contamination of the urethra because the urethra is at the front of the perineum, so we wouldn't do that. C, empty the bladder when there is an urge to void. Absolutely. If you ignore the urge to void, you're going to hold on to urine and potentially increase the risk of UTI. Wear synthetic fabric underwear. No, that's not a good idea. That increases the risk of bacteria entering the urethra and getting into the bladder. Take a shower daily. Sure, I think that's a good idea. Good hygiene, although I'm going to tell you most UTIs, people have good hygiene already, but that would still be good advice. So answer there, A, C, and E. Okay, let's look at the next question. Nurse is caring for several clients. Which of the following clients are at risk for developing pyelonephritis? Select all that apply. A client who is 32 weeks pregnant. Absolutely. Pregnant women, I mentioned the uterus can compress the ureter and cause backup of urine into the kidney and lead to pyelonephritis. Okay, which is not a good thing in pregnancy. A client who has a kidney calculi. Well, if the kidney calculi is in the ureter, that would block urine flow and back up the urine into the kidney, increasing the risk of pyelonephritis. So that would be correct. A client who has a urine pH of 4.2, that's acidic. So bacteria do not like to live in acidic urine. And that's partly why people take vitamin C to try and prevent UTIs. So, no. D, a client who has a neurogenic bladder. Absolutely. If you have a neurogenic bladder, often you have to perform in and out catheterization. That increases the risk for UTIs. And also, the urine is sitting longer in the bladder until it's emptied, right? So they're definitely at risk for UTIs. E, a client who has diabetes mellitus. Absolutely. In diabetics, they can leak some sugar from their bloodstream into the urine, and bacteria love to eat sugar as well, and it increases the risk of developing a UTI. Okay, so the answer there is going to be A, B, D, and E. Okay. Number 5, a nurse is reviewing urinalysis results for 4 clients. Which of the following urinalysis results indicates a UTI? Positive for hyaline CAS. Well, CAS always come from the kidney. Okay, so a cast is basically formed when cells or protein get stuck in a nephron and form a cast and then get released into the bloodstream. So you can have white blood cell casts in a pyelonephritis, since there's white blood cells that are trying to attack the bacteria, but not a hyaline cast. Okay, positive for leukocyte esterase, absolutely. It's going to be B. Positive for ketones. So ketones in the urine are an indication of diabetic ketoacidosis, dehydration, starvation can cause ketones since you're breaking down fatty acids. Positive for crystals, no. So, I mean, crystals can come from uric acid crystals, but that's not an indication of a UTI at all. It's leukocyte esterase, B. Okay, so last topic, renal calculi or kidney stones. So most kidney stones are composed of calcium. So whether it's calcium phosphate or calcium oxalate, they're formed in the kidney. Okay, and if they remain in the kidney, they don't cause any problems at all. It's when the kidney stone leaves the kidney, travels into the urine, into the ureter, is where all the problems begin. And we call that renal colic. Okay, so the condition of having kidney stones or urolithiasis is it just depends on where the kidney stone is. So if we do an ultrasound and look at someone's kidney and see that they have kidney stones within the kidney, well, they don't have any symptoms from those. It's when they leave and travel into the ureter, causing acute renal colic. Okay. Now, there's other types of stones. There's uric acid stones. Remember, elevated uric acid in the serum can cause gout, and it also causes the buildup of uric acid in the kidney, leading to uric acid stones. Okay. There's another type of stone called a struvite stone and a cystine stone. And how do we determine which ones people have? Well, we try and get the stone, right? We try and obtain the kidney stone by filtering the patient's urine through a little filter. Especially if it's the first time they've had this, we try and obtain the stone and send it off for analysis. Okay. So when we're talking about calcium stones, which are by far the most common, it's not usually because we have a diet high in calcium. It's usually due to some kind of pre-existing metabolic issue in the patient, or a family history of calcium stones. There's some kind of defect or pre-existing condition causing them to create these stones. Okay. The majority of people will pass a kidney stone that's traveling from the kidney to the ureter and getting deposited into the bladder. Okay. People often ask, is this stone going to hurt when I pass it through my urethra? And most of the time it doesn't, because they're quite small. So what's considered a small stone? Typically anything less than 5 millimeters is considered a relatively small stone. They're still exquisitely painful. A medium-sized stone would be, say, 5 to 8 millimeters, and then 8 to 10 millimeters, they're getting to be large stones. So the larger the stone, the less the chance that the stone is going to pass, and it's going to get stuck in the ureter. So for example, if we see someone has a 10 millimeter stone stuck in their ureter, there's a pretty small chance of passing such a large stone, right? Compared to, say, a 3 or a 4 millimeter stone, which is very likely going to pass. Okay, so when we think of the causes of kidney stones, most of the time we actually don't find a cause. Okay, it is more common in males, and typically there's a family history of kidney stones. So when someone comes in with a kidney stone, that's landed in their ureter and causing acute pain and nausea and vomiting. Typically, they'll tell us that someone else in the family has had a history of kidney stones. Okay. And what's the biggest risk factor for patients developing kidney stones? Well, yeah, it's definitely genetic. They could have an underlying metabolic problem that leads to hypercalcemia. So let's say hyperparathyroidism causing hypercalcemia. But another big risk factor is not drinking enough. If you don't drink enough, the urine becomes concentrated, and that allows calcium to crystallize and form kidney stones, whether they're calcium phosphate or calcium oxalate. Okay, so really drinking drinking a good amount of fluid daily, like 2 to 3 liters of fluids, will prevent kidney stones from forming. Okay. In terms of hyperuricemia, which is high uric acid in the bloodstream, well, that can occur again from from inherited or genetic history. So there's a family history of gout, say, or uric acid kidney stones. And where does uric acid come from? Well, it comes from the breakdown of DNA and RNA. So it comes from diet as well, right? So if you're eating a diet very high, for example, in organ meats, you're going to be consuming and producing large amounts of uric acid. Okay, because purines, which are in DNA and RNA, uric acid comes from the breakdown of purines. So I mentioned that most people will pass stones, especially if they're smaller stones. So when they enter the ureter becomes really inflamed and irritated, and it goes into spasm, and that's where people get this acute back pain due to the spasm of the ureter and also the backup of urine into the kidney, causing hydronephrosis. So they get a dull pressure in their back. But the acute pain is really from the spasm and inflammation of the ureter as the stone is trying to make its way down to the bladder. Okay, very painful. And again, most of the time, kidney stones will be passed. The average time span to pass a kidney stone is about 7 to 10 days. Okay, so it's not typical that you pass a kidney stone in one day. Lithotripsy is a beam that's aimed at the stone, and it tries to break it up into smaller bits that can then travel down the ureter. Okay, so it's done in an attempt to break up a larger stone into much smaller stones that can then pass. Okay, so risk factors for kidney stones we spoke about: male, poor, decreased intake of fluid is the big one, right? So really, patients who have really a poor intake of fluid, or they're recurrently dehydrated, are at higher risk for kidney stones because they're producing concentrated urine, which then creates crystals such as uric acid crystals and uric acid stones, or calcium phosphate or calcium oxalate. Okay, there are metabolic conditions. I mentioned hyperparathyroidism as one that causes hypercalcemia. Patients with high oxalate diet. So where does oxalate come from? Well, black tea is a big offender. Chocolate, beets. So oxalate binds with calcium to form calcium oxalate stones. So that's why reducing oxalate in the diet can be important. Okay. And purines, well, purines are in DNA and RNA, and so food that's increased that's high in purines, such as a piece of liver, some organ meat, very rich foods. The body breaks them down and produces uric acid. Okay. So what's the expected findings of a kidney stone, or what we call renal colic, when it's in the ureter? Well, severe, sudden onset of flank pain, right? Um, Vomiting, nausea, they look pale, they're sweaty, and often they'll say, I noticed that my urine's a bit red. They have hematuria, okay? They don't usually present at the beginning with a fever, okay? Because it just happened suddenly. The stone left the kidney, went into the ureter, and caused this acute pain, nausea, vomiting, and potentially some hematuria. If the stone remains stuck in the ureter, the urine can certainly get infected that's above the block stone and lead to pyelonephritis. Okay? And that's where the fever comes from, because the urine is now getting infected above the blockage. So the flank pain, as the stone travels down the ureter, often becomes lower, and then it starts to radiate into the lower abdomen, the left or right, depending on which side has the kidney stone, and it often will radiate into the groin and the scrotum in males, or the vulva in females. They'll have a sensation there. Okay, people often say, I need to go to the washroom frequently. I have urgency, and it's not from an infection. It's from this stone that's traveling down the ureter and giving them this sensation. Okay. Often they come in very anxious. They're tachycardic because of the pain. They have increased blood pressure because of the pain. They're pale, diaphoretic, again because of the pain. Okay. Okay, so let's just clear something up here. So nephrolithiasis is kidney stones, right? The term nephrolithiasis, which is in your book, is kidney stones. If a stone leaves the kidney and travels into the ureter, that's when all the trouble begins with renal colic. You don't usually form stones in your ureter. You form the stones in your kidney, and if they stay in the kidney and never leave it, there's no problem. It's when they leave the kidney and travel and get stuck in the ureter, and they try to pass to the bladder. Okay, so let's look at some different aspects of caring for someone with renal colic. Remember, if they have a kidney stone in their kidney, it doesn't matter. It's not causing any symptoms. So I think when you hear the term, this person has a kidney stone, we're really talking about renal colic. Okay. So what do we want to do? Well, after we get vital signs, so temperature, blood pressure, heart rate, O2 sat, we want to take them out of their misery because they are super uncomfortable. And we use opioids such as morphine, hydromorphone, an assortment of different opioids, and definitely NSAIDs. So non-steroidal anti-inflammatories are extremely effective for treating the inflammation and pain of renal colic. Okay. So it's usually a combination of opioids and NSAIDs. The spasmolytics we don't use very often. Oxybutynin is actually a bladder relaxant. It's an anticholinergic, and that's usually used more for urge incontinence. We don't use it very much for renal calculi. I know it's in the chapter, but it's really not used for that. Antibiotics only if there's a development of a pyelonephritis above the obstruction of the ureter because of the stone, right? So we don't give people antibiotics for renal colic we give antibiotics for the complication of renal colic, which is pyelonephritis. Alpha blockers. So alpha blockers can be used, and so you may have heard of alpha blockers in patients with BPH. It relaxes the sphincter in the prostate and allows for better urinary flow. We also use alpha blockers because they've been shown to help with the passage of the kidney stone within the ureter. Okay, so that's the reasoning that we use alpha blockers. So really the mainstay of treatment is pain control, opioids and NSAIDs, antibiotics if they develop an infection, and sometimes we'll give an alpha blocker because it helps with the stone passage out of the ureter. So what kind of NSAID do we use? Well, typically we use one called ketorolac. Is it better than ibuprofen? No, but it happens to come in an IV formulation. So that's the reason why we typically use it, because these patients come in nauseated and vomiting, and they really can't take much by mouth, so we use an intravenous NSAID called ketorolac. In terms of patient education, the bottom left, so if this is the first time they have a kidney stone, we ask them to strain their urine to see if we can catch the kidney stone for analysis to see exactly what kind of stone they have. Okay, we don't always get it. They don't always see it. Sometimes it's a tiny stone and they don't see it. We do encourage increased fluid intake. Again, just to maintain proper urine output. There's an idea that if I drink lots and lots of fluid, I'll push the stone down the ureter faster. That's not the case. That's a myth. Okay, that wouldn't happen. Some patients require IV fluids because they're vomiting so much, right? So they're getting IV opioids, they're getting IV NSAID, such as ketorolac, and they're getting IV fluids to maintain hydration. Okay. Encouraging ambulation. Sure, if the patient's able to. They're often nauseated and vomiting, but if they're able to walk around, we encourage it, because renal colic is a condition where you really can't keep still. You're so uncomfortable that you really just don't want to lie in bed. But typically after we've given an NSAID and an opioid, they become much more comfortable. Okay? So what do we monitor? Well, we monitor the vital signs. That's number one, always, vital signs. Pain status. How comfortable are you with what we've given you in terms of opioids and NSAIDs? And monitoring of input and output of fluids. Okay? Initially, the input of fluids is coming in the form of IV fluids. And we monitor urine output. I'm going to tell you in real life, we don't monitor urinary pH at all. Okay. So let's go on and talk about complications. So if you know the mechanism of what's wrong, you can predict the complications. So the mechanism is that there's a stone blocked in the ureter. So there's going to be backup of fluid to the kidney, and that's going to cause hydronephrosis, which in itself, for a short period of time, is not a problem. Okay, so patients often have hydronephrosis from a kidney stone. The problem is that this blockage, this obstruction from the stone in the ureter, and the backup of fluid to the kidney can result in pyelonephritis. So we always tell patients, we need you to come back to the hospital if you develop a fever, because that can indicate a kidney infection, and you'll require antibiotics, okay? And if it goes beyond the kidney in terms of infection and they develop urosepsis, they can become extremely ill, okay? So that's the main complication. Hydronephrosis due to the obstruction, leading to pyelonephritis and urosepsis. Okay, so how do we determine if someone has a kidney stone? So let's look at the procedures at the bottom right. Well, typically it's pretty classic because they come in pacing, they're sweaty, they're pale, they have flank pain, they're nauseated, they're vomiting, and they may report some hematuria. Okay, and typically they also report that they've had it before. Okay, so a KUB, which is kidney, ureter, bladder, is just an X-ray of the abdomen. It's relatively useless unless it's a calcium stone and it's large enough for us to see. Otherwise, we don't see the other stones. So the most common test we use for looking at a patient with renal colic is a renal ultrasound, looking for hydronephrosis, and a CAT scan. And the advantage of a CAT scan is it not only tells us that there's hydronephrosis, it also tells us the size of the stone, whereas a renal ultrasound does not tell us the size of a stone. Okay, so let's look at some procedures to clear a blocked kidney stone that's in the ureter. So there's lithotripsy, so extracorporeal shockwave lithotripsy, or lithotripsy, basically uses energy in the form of sound or shock waves to break up the calculi or the kidney stone into little pieces, little gravel that will then go down the ureter and pass into the bladder. Okay, this will require some sedation. Okay, it's breaking up the stone, and all those little bits are going to travel down the ureter, so it can be painful. Okay. There's one that's mentioned in your book called non-surgical chemolysis. I've never heard of a drug that we use to break up kidney stones or to dissolve them, so I won't comment on that. There are surgeries that are sometimes required for kidney stones that aren't passing, such as stenting of the ureter. So stents are inserted initially with a cystoscopy, so they go into the penis or into the urethra of either male or female, and they stent the ureter. They put a stent there and allow the passage of the stone. Okay. They can sometimes also go with a cystoscopy into the bladder, and with a basket or a loop, they can grab the stone and pull it down. Okay, so these are really for obstructed ureter stones. And also there's open surgeries. If there's a large stone that's blocking the ureter, they can make an incision and remove the calculus from the ureter. If there's a huge stone that's in the renal pelvis that's obstructing flow of urine, then they can also go and remove that. Okay, so it just depends on where the stone is. Okay, so let's just talk briefly about diverting urine. Why would we ever want to divert urine from the bladder? Well, if there's a disease of the bladder or something that's really malfunctioning with the bladder. So how about bladder cancer or other pelvic malignancies that are impacting the bladder and making it non-functional? Or the bladder has to be removed for the bladder cancer. Congenital birth defects of the bladder can occur and make it non-functional. Trauma of the bladder, chronic strictures of the urethra, so the bladder can't empty properly. Neurogenic bladder that's causing repeated infections and a real problem for the patient. So what they can do is take, what can be done is the two ureters are cut away, and a piece of the ileum, so a piece of the distal small intestine, is cut off, and they attach the two ureters to the small segment of the distal ileum, which has now been removed from the small intestine, and They attach the two ureters to it, and then they attach the other end of it to the abdominal wall. And that's called an ileal conduit. Okay, so, and you get a urostomy. Okay, and the urostomy bag fills with urine. Okay, I often wondered why people wouldn't get recurrent pyelonephritis from a urostomy. Because a segment of the bowel is being used as the tube from the ureter to the abdominal wall. But in actual fact, it's not connected to the gastrointestinal system any longer. Okay. Okay, so I'm going to stop here. I know this was a long module, and I apologize for that. I know there's repetition built into it. And repetition, I think, is how you gradually just learn topics and hold on to them in your mind. Okay. Okay, let's do the questions at the end of chapter 61. Number 1, a nurse is completing the admission assessment of a client who has renal calculi. Which of the following findings should the nurse expect? So, bradycardia, no, they're going to be tachycardic. So, a renal calculi, I'm just going to assume that it's renal colic, okay? Because the term's kind of interchangeable here, it seems. So, renal colic, they're going to be, so flank pain, nausea, vomiting, hematuria, sweating, tachycardic. They are super uncomfortable. They're pacing. They can't keep still, right? So, not bradycardia. Diaphoresis, for sure. Nocturia, no. And so nocturia wouldn't be a cause of nocturia would occur in, say, someone with BPH, someone who's not completely emptying their bladder. So now they're having to get up 2 or 3 times a night because they never emptied their bladder to begin with. Okay. Bradypnea is slow breathing. No, they're going to be breathing fast. They're in pain, so it's B. 2, a nurse is reviewing discharge instructions with a client who had spontaneous passage of a calcium phosphate stone. Which of the following instructions should the nurse include in the teaching? Limit intake of food high in animal protein. Yes, that is true. We didn't go over that segment in the book, but that is true, that limiting animal protein can reduce calcium phosphate stones. Reduce sodium intake. That is, again, true because it also limits the production of calcium phosphate stones. Straining urine for 48 hours. If the stone has passed, there's definitely no need to strain any urine any longer. Okay. Report burning with urination to the provider. That's true for sure, right? So whenever you've had a kidney stone, there is a risk of developing a UTI. Now, it's uncommon to develop a UTI after you've passed the stone, but it's possible, right? So reporting burning with urination is definitely appropriate. Increase fluid intake to 3 liters per day. Yes, good idea. And really, that is the way to prevent kidney stones. Increase your hydration every day. Keep that urine dilute so you don't form new stones. Okay? So the answer is A, B, D, and E. Okay? Number 3. A nurse is teaching a client who is scheduled for lithotripsy. Which of the following statements by the client indicates understanding of the teaching? I will be fully awake during the procedure. Typically, they're sedated for this procedure because it can be uncomfortable. Lithotripsy will reduce my chances of having stones in the future. That's not true. This procedure is to break up the stone that's causing the issue this time. I will report any bruising that occurs to my doctor. No, that's an expected finding with this shockwave lithotripsy, so it wouldn't need to be reported. Straining my urine following the procedure would be important. Yes, that would be important, so that the stones can be captured, right? Especially if it's the first stone. We really want to know what kind of stone they have. Okay, so the answer is D. 4, a nurse is caring for a client who has a left renal calculus and an indwelling urinary catheter. Okay. Which of the following assessment findings is the priority for the nurse to report to the provider? Flank pain that radiates to the lower abdomen. Well, that would be from the left renal colic. So from the kidney stone that's blocking the ureter, right? Client report of nausea. Now, nausea and vomiting is very common in renal colic. Absent urine output for 1 hour. Okay, I don't really like this question. If you think about it, we have 2 kidneys usually, and the other kidney continues to make urine. So how would you have absent, and you would never have bilateral kidney stones blocking both ureters. In absence of urine for 1 hour. In actual fact, I would have chosen a white blood cell count of 15,000, because now I'm getting concerned that this person is developing an infection on top of the kidney stone. So I think that's a more important one. Absence of urine for 1 hour. Yeah, I don't really understand that, because the other kidney is still fully functioning. So sorry, I can't help you with that question. Well, I can only help you when when I think they're accurate. Okay, number 5. A nurse is completing discharge instructions with a client who has spontaneously passed a calcium oxalate stone. To decrease the chance of recurrence, the nurse should instruct the client to avoid which of the following foods? Okay, so oxalate, really high in black tea, okay, and also can be high in spinach, okay. So red meat would not be the answer, but black tea for sure, that contains quite a bit of oxalate. Cheese, not so much. Whole grains, not so much. And there's spinach, okay? So it's going to be B and E. So I would just refer back to the chapter, and I think it lists all the foods that are high in oxalate.